work at the Rwanda Military Hospital, and I'm also a lecturer at the College of Medicine. So our course have clear learning outcomes. We are going to discuss about the history taking, the physical examination. We will discuss about the differential diagnosis, how you do propose investigations, and how you plan a treatment approach. So by the end of the course, I hope you are going to use your knowledge about the pathogenesis, the symptomatology for the general surgical diseases, and you would have you would be able to apply your surgical clinical examination and how to examine a trauma patient, and finally we can have a case presentation in surgery if time allows. I assume you have already done your embryology, your gross anatomy, your physiology, the basic concepts on microbiology and pathology, because you're going to need it possibly in this course. The most important things in approaching a patient is about ethics. So we're going to look at the ethics in our approach to the patient. We will have a brief overview on the history taking, on the clinical examination, the investigations, how to make differential diagnosis, then the treatment approach. And for the ethics, these are principles and values that always govern the professional conduct. And here you have to differentiate what is right and what is wrong. In medicine, we have principles, 4 principles, which are very important, what we call the autonomy, the beneficence, the non-maleficence, and the justice. What is autonomy? Can someone tell me what is autonomy?
Autonomy is quality.
Come again? What did you say?
I said that autonomy is like self-governing quality.
So, semiology, which is the course you are doing now, is defined as science of signs in general. Science of signs means we are going now to learn how to interpret symptoms, how to observe signs from the patient and make them important and conclusive to get a disease and to get a treatment plan. So when you approach a patient, there is more to being a good clinician. You have to be a good listener. You have to use your knowledge. And one way to reconcile the expectations with your inexperience and the incomplete knowledge or skills is to put yourself in the situation of the patient or their relatives. Me, how should I approach this situation? And you have always to consider how you would wish to be with patients. Always preserve their dignity by observing the following: attitude, compassion, and dialogue. How would I be feeling in this patient situation? That's your attitude. The behavior is always treat the patient with kindness and respect. And you have always to recognize the human story that accompanies each illness. It's not only about the disease, it's about the story behind or around the disease. And you have to acknowledge and understand the patient who is in front of you. So doctors who communicate well are able to identify a patient's problem more rapidly and accurately. And good communication skills are the most important part of being a good doctor. So communication skills are learned. You don't come early in the morning and get the communication skills. No. you learn them by the time you approach your patients, you learn them by the time you get more skills. And poor communication skills are mostly associated with increased medical legal vulnerability and burnout. Here I can tell you and guarantee you that whenever you touch a patient, you are touching a file in the court. That means if you treat well the patient, it's okay. The patient will thank you. But if you treat wrongly the patient, be sure that the patient anytime can sue you. And when they sue you, problem starts. So always bear in mind that poor communication skills may bring you problems, and never be complacent about your communication skills. They will develop with experience, but can always be improved by the time. So when you have a patient in front of you, always maintain a good eye contact. Check the patient's prior knowledge or understanding. You need to be a listener and ask the patient to interact. You need to encourage verbal and non-verbal communication. You need to avoid jargon. One of you can mute the microphone. Please, all of you mute your microphone. Check if you have muted your microphones. Okay, and you have to avoid jargons. Jargons means unclear language or slangs. You have to avoid them when you are talking to a patient. And you have to be elicit and address the patient's agenda. Always recognize the patient's timing and have to discuss difficult issues with the patient. And you have always to keep the same pace that is comfortable for your patient. So when the patient visit a doctor, it's because they have something unexpected that happened to them. It can be a minor or major complaint or something that is not right. And most patients have formed some idea of what might be wrong with them and have worries. Many of them come to see you after they have Googled their diseases, their illnesses, and some of them have concerns they wish to discuss. The first and major part of the consultation is to talk to the patient. So communication is basic, it's paramount, and that is the first point to learn when you are learning introduction to clinical skills. So reason why people visit the doctors, they have reached their limits of tolerance, they have reached their limits of anxiety, they have problems of living presenting as symptoms, and they see you for preventing any problem, or they can come to see you for administrative reasons. These are most common reasons why people visit doctors. So think about the last time you sat in a doctor's waiting room when you were a patient. How did you feel? What were your ideas and expectations? What happened exactly? How was your communication? Did a good communication support the building of trust between you and the doctor and helped providing clear and simple information? So always ask yourself, what was my last time I sat in a doctor's waiting room? Because that's how you are going to approach this course, how you are going to know exactly how to talk to a patient. Communication means much more than taking a history. It is the only way to effectively involve patients in their health care. You have always to ask the patient. And the poor communication leads to misunderstanding, conflicting messages, and patient dissatisfaction. So poor communication is the root cause of complaints and litigation. Please, when you have a patient that you are talking to, make sure that the communication goes well and make sure that there is no misunderstanding, that there is no confusion, that everything is right so that there is enough satisfaction of your patient in front of you. So always to improve satisfaction, you have to understand what is wrong from the patient perspective, because they understand what they can do to help. And you have to improve the doctor satisfaction. Patients are more likely to follow advice when they agree mutual goals with the with the doctors. And to improve the health by positive support and empathy, you need to improve health outcomes. You need to enhance the relationship between the doctor and the patient and use the time more effectively. In this case, we mean active listening helps the doctor recognize what is wrong, and then active listening leads to fewer patient complaints. At the beginning, you need to set up your location. You need to be prepared, and you need to introduce yourself. You need to be an active listening, the patient experience of their illness, and you need to have a systematic inquiry, disease-oriented systematic inquiry. You need to get a thorough clinical examination and understand your patient as a person and share information or agree on actions and goals. So how do you make your setup? Where will you see your patient? The patient privacy is mandatory, always. If you have other staff or students with you, introduce them and ask the patient's permission for them to be there. How long will you have? The length of consultation varies according to the countries. For the new case, it can take up to 13 minutes in UK, 10 to 20 minutes in Rwanda. On the bedside, it varies. It can be 5 to 10 minutes for the patient. So for complex cases, they can take up to 30 minutes and more. So always learn to give enough time to your patients. Arrange the sitting in a non-confrontational way. Turn away from the screen to talk to your patient. At a bedside, pull up a chair and sit at the level with your patient to see them easily and gain in a close eye contact. So for the non-verbal communication, always remember your attitude, your dress code, and the behavior, and show that you are concerned to the patient's situation and avoid interruptions such as the telephone calls and so on. So this is a simple example how you should be towards your patient. And this is an example of what you should never do to the patient, because this interrupts your communication to the patient. So starting your consultation, you have to make sure you are talking to the correct patient. You have to introduce yourself so your patient knows who you are and what you do. It may be appropriate to shake hands and to use the patient's and your own names to confirm identity. If possible, shaking hands, this depends on the needs. You have to tell patients if you are in training or if you are usually eager to help. And look at the patient records and at any transfer or admission letters before you start the conversation. You take notes, but it should not interfere with the consultation. So this is an example. Good morning, Mrs. Claire. I have got the right person, correct? I'm Dr. Kayisire. I'm a second year medical student. I've been asked to come and talk to you and examine you. This might take 20 to 30 minutes if that's all right with you. So this is the perfect way of introducing yourself to the patient, telling them the expected to have with them, and also make sure that they know your level of knowledge. I see that you can't really get out of bed, so we will need to talk here. Pull the screen down. I'm sorry it is not very private in case the room is noisy or there are many people. If I ask you a question that you don't want to answer in case other people over here, just say so. So this is always to make sure that the patient is comfortable, that the patient trusts you, because it's very important for the privacy of the patient. Another example is, I will need to make a few notes so that I don't forget anything important. Now, I'm writing things down. It doesn't matter to you, I still will be, don't worry. Are you happy with all of that? So All of these are important clues, questions you need to address to the patient so that they know exactly that you are concerned, that you're because the words you use may changing depending on the situation. So actively hearing the patient's own story about their illness experience and what has actually happened is vital. The way you ask a question is important. Open questions encourage the patient to talk, but closed questions don't help talk. However, they give you a clear understanding with the yes or no answers. So both types of questions have their place. You need to know when to use them and confuse them when you are addressing a very concerning um, question. Once you have established what has happened, find out about your patient's five. Five means the feelings, the ideas, functioning, and expectations. The feelings are related to the illness, the ideas on what is happening to them, the functioning in terms of the impact on daily life, and the expectations of the illness, and your expectations as a doctor. So dealing with feelings, illness can cause anger and frustration, and when consulting, you will encounter angriness or distress from the patients, and getting angry yourself or ignoring the emotion does not help at all. So if you feel angry with your patients, it is likely that they feel angry themselves, but there is something wrong. So you need to recognize the emotion and show understanding to encourage your patients to talk and offer what explanations you may have to them. Please, can you mute your microphone? Please, that you have muted your microphones. Thank you. So you will always be talkative over familiar patients or those who want to deal with a lot of things at once. So you need to stop them. And you need to set a professional boundaries if your patient becomes over familiar. And you may suggest of the 6 things you have raised, I can only deal with 2. Can you tell me the most important? This is the best way, the perfect way to stop a very talkative or over familiar patient. So you have to be empathic, and this helps the relationship between you and the doctor. And empathy and sympathy, those are expression of sorrow. It is very important. Think how you would feel and imagine yourself in that position, and this helps a lot to know how to deal with the patient. So you have always to understand the context of your patients. So you need to know the personal constraints and supports patients live, who they live with, where they work, who they work with, what they actually do, their cultural religious beliefs, the relationships and past experience. You have to be sensitive to and tolerant to all those issues, and you should never judge the patient. You have to recognize the feelings, the emotions, and the context of your patients. You have to clarify and summarize what you say. You have to use words that your patient understands, know who you are talking to. A lawyer is different to a pharma laborer. You need to use simple language and ensure your patient understands the treatment options and likely prognosis that they may know. So you need also to engage your patients in the decisions. You can make suggestions, encourage patients to contribute with their thoughts, and you can agree on realistic goals. Example: stop smoking, or having a palliative treatment, and with a complex discussion by briefly summarizing what you have agreed, or ask your patients to summarize for you. So talking to your patients as a summary You have to speak clearly and audibly. You do not use jargons. Do not use unnecessary motive words. Listen to the patient's story, and you have to find out about them as individuals, as a persons. You have to clarify. You have to negotiate, meet your goals, and finally, you can summarize. You have discussed with your patients. So this is the time you need when you are talking to the patient. You need to decide on the type of pathology by knowing exactly at which onset. Was it abrupt, hours? Was it sudden? Was it very variable? And the progress, which can take either hours, weeks, or years, and associated symptoms, either fevers, symptoms of severity, and steadily progressive to remission or not. So by deciding Socrates, how we know it, S as site, onset, character, radiation, associated symptoms, timing, exacerbating and relieving factors, and severity. So associated symptoms, you have to note the nausea, sweating, faintness, visual disturbance that may precede migraine, palpitation, and the pain disturbs sleep. A pain which disturbs sleep suggests a physical cause. So those are important questions you need to ask to recognize well the patient's pain condition. So with all the relevant information assembled, you should have a list of differential diagnoses before you examine the patient. Briefly summarize what the patient has told you. Reflect this back to the patient, tell the patient what you are going to examine, and gain the permission to do so. This is an ethical principle to that. So, about calculating the pack years of smoking, you take the number of cigarettes smoked per day times the number of years smoking divided by 20. For example, 20 cigarettes equal 1 packet. For example, a smoker of 10 cigarettes a day who has smoked for 15 years would smoke 7.5 packets. So this is very important to know when you are dealing with patients who have chronic respiratory disease. So ask abruptly how much alcohol do you drink may upset patients. So try always to be soft. Do you ever drink any alcohol? This workout with them would match and help easily. Use open questions, giving permission for them to tell you, and do not judge the patients. Follow up with closed questions covering what, when, and how much. So for calculating units of alcohol, the standard measure is 1 unit, 1 small glass of wine, 1/2 pint of beer, 1 shot of spirits. Standard measure, 1 unit equals to 25 mils of 40% alcohol. And this alcohol equals 10 mils of ethanol. So from that, you may calculate how much the patient has consumed per week of alcohol. So to describe wounds, you need to know the position well on the body, including which aspect of a limb, the size, orientation, example 5x3, the appearance, example colon shape, the type of lesion, abrasion, scratch, bruise, laceration, incised wound, penetrating wound. And when you document the findings, always record the date, the sign your findings, investigations, and management plan for the patient. Record objective findings only, record all abnormal findings, but only record the negative findings if they are relevant. The notes are confidential, and details must be shared only with the professionals directly involved in the patient's care. Patients have the right to see their case notes. They can ask you, if they ask you, you can show them their the records you took about their history taking. Do you have any question about this history taking? Any question?
No.
No question. Okay. Now let's see on the general examination of a patient.
I have a question. Sorry, teacher. Sorry, teacher. I have a question. Yeah. About the principles for medicine, I've seen that always the information of the patients are confidential. So how can you deal with the rego issue once they arise?
Come again with your question.
So I'm asking for how can you deal with the rego issue when the patient has come for you, and then you have to keep his security, say his or her information confidential. Why do you need to provide them to the some investigators who are dealing with some rego issue?
So that's one of the exception. The confidentiality means you are protecting the patient. But when you are protecting the patient, you are also protecting at the same time the society. And if there is any problem engaging the patient to the society, and there is any need of breach of the confidentiality for the sake of the society or for the sake of the relative of the patient or for another patient at all, it means divulgating those informations are not considered as breaching the confidentiality principle. It's about helping an investigation on an ongoing case. It does not mean you have breached your confidentiality process. No, it means the legal case is needed for the safety or for the interest of the society. That is very important. Let's take a very simple example. You have someone in a family who is sick and who has a contagious disease. Are you going to keep the secret of that contagious disease and let the patient contaminate the whole family? No, you cannot. That means you have to use your common sense. Best for the patient. And the best for the patient, sometimes they don't know. And if the patient is going to contaminate others, that is not beneficent. It means you need to so it's the same for the legal cases. So when you provide information to the investigators, it's either for the benefit of the patient who has requested a court trial, or it's for the benefit of the society. So there is no breach of confidentiality in such a case. Any other question?
Yes. Yeah, my question was on the things you talk about, that first you have to say if you are a trainer of product. I think it can be somehow hinder your investigation if the patient know that you are training, you are professional, and can minimize his confidence, and so that you cannot take the good history as you can.
What's your name? Do you prefer or someone who takes
truth?
The truth. The second question: Do you expect that know about everything? Okay, so let's take a very simple example. You are dealing with a very experienced doctor. Do you think that know about everything?
No.
So what if that doctor who is very experienced starts lying to you, pretending they know about everything? Will you be comfortable?
No.
No. And if that doctor who is very experienced tells you that they have some weakness in some subject that they don't master very well, but guide you someone who can help you, don't you think that is going to be better than someone who comes and lie to you?
Yeah, it will be more better.
For the student. So telling your patient that you're a student does not undermine you. No, it does not. It shows to the patient that you recognize your position, that you recognize your level of knowledge, and that you are there to help with the best you can. It does not undermine you. It gives the confidence and trust to the patient, because the patient is going to see someone who is truthful, someone who recognizes the weakness, someone who recognizes a set of knowledge. And that means if you are progressing in your discussion with the patient, after saying you're a student, you are protected. There are some information you may not be disclosed to the patient. There are some actions you may not be able to do to the patient, because you're going to tell, I'm a student, I'm going to report this to my superior, then comes back to help you. That is very important, always to recognize a weakness or a certain level of knowledge. In my daily practice, even if I'm a surgeon, I never pretend that I know everything, because I don't know everything. There are things I do not know. And in that case, when I don't know, I tell the patient I do not know, but I tell them what I can do for them. Remember, when the patient comes to see you, they need help. They don't need magics. They need help, and they have expectations. So if you start lying them, it's not going to build your relationship. It's not going to build the bond between you and the patient. Okay? That means if you're a student, always introduce you as a student. It does not undermine you. Trust me. It gives you the confidence of what you can, and it gives you the protection of what you cannot do, because you will always be supported by someone who is superior to you, who is senior to you, and that person is going to help you whenever you are blocked with your patient. But that confidence with your patient will be built, and if any time the patient comes back, they will know that gentleman, he helped me a lot, because he knows that he's a student, but at least he helped me even better than the doctor. Did you know that you can help the patient better than a doctor? Christian?
Yes, I can.
Yes, you can. That means you have to do it recognizing your level of position. It does not undermine you, and trust me, always be truthful to the patient. It protects you, it supports you, and it builds a strong relationship between you and the patient.
Yes.
Good.
Thank you.
Good. Let's go to the next part of the general examination. After examining the patient, you have to it's sensitive to what you're going to do. You don't need to expose all the areas of the body of the patient, only expose what you are going to examine. For example, you're going to examine the head. You don't need to expose the back of the patient. You are going to examine the foot. You don't need to make the patient uncover the chest. So that means always expose only the part which is being concerned. You have to cover the rest of the patient with a sheet and always consider the gender. Tactfully ask relatives to leave the room before the physical examination, but not always. For example, you need a translator, or you can also request the patient's wish. Always collect together all the equipment you need before starting the examination. So about making the relatives leave the room, you have to be very careful on some patients, okay? That is a practical situation I'm going to share with you. For young ladies, if you're a doctor and you're a man and you have a young lady who is coming to for consultation, always make sure that there is a nurse, female, in the room. That helps preventing any misunderstanding or unnecessary misinformation. And if you are a man, better to have a nurse or any nurse in the room so that it helps also to prevent any misunderstanding or misinformation with the patient. So for the things you need in the room, you need a stethoscope, you need a pen torch, you need a measuring tape, a telephone hammer, and a thermometer. You need disposable lubricant gel and a proctoscope if you need it, and some facilities for obtaining blood samples, urinalysis, and fecal occult blood testing can be available in the consultation room. So the sequence of examination, you all know: inspection, palpation, percussion, and auscultation. You have to go through these four sequences of examining the patient. And anyway, if there is no single correct way of performing physical examination, always start with the best one, depending on what you need to do to you. So, the summary: you introduce yourself to the patient, including handshake and first and impressions. The patient, getting a history, collect the presenting complaint, getting other history, past history, drug history, family history, social history, occupational history, travel history, sexual history, tobacco, alcohol, and you need to get a systematic inquiry. You make your differential diagnosis, you examine the patient using a systematic approach, and finally you confirm or refute your diagnosis. Please, can you mute your microphone? Please make sure you have muted your microphones, all of you. Good. So how to examine a swelling or a mass? You have to look at the size, the position of the site, the attachment around the tissues, the consistency, the edges, the surface and shape, the pulsations, and inflammation. For the site, you need to detect significant changes. You need to look at the origin, which has been determined, and the consistency may vary from soft to stony or solid. Edges might be regular or irregular. Surface can be smooth or nodular. Pulsations, frills in case of vascular supply, and inflammation to look for any redness, tenderness, and warm. And finally, transillumination in case of hydrocele or cystic masses. So this is examining a mass or a swelling. You use the mnemonic of speed. The first S is for the size, the position, the attachment, consistency, age, surface and shape, position, inflammation, and transillumination. You have to measure the body mass. If you want to measure the body mass index rather than the weight alone, because it is independent of the patient's weight. So the BMI is calculated from the weight over the height over the height, and this is a very important information when you want to calculate the overweighting or obesity of your patient. So the BMI is also the nutritional status, and can depend on the ethnic group. And you need to know all these levels for the underweight, for the normal, for the overweight, for the obese, and morbidly obese. These are very important to know. So for the obesity, it is caused by excess calories intake associated with inadequate exercise, and obesity reduces life expectancy by 10 years. And the weight loss is importantly clinical, and it may be caused by a chronic disease, a serious or prolonged infection, or a chronic inflammation. So complications of obesity are multiple. They can start from the head, the chest, to the abdomen, up to the legs. So very important to know all these complications of obesity. There is a lot of physiology and pathogenesis behind these diseases.
Excuse me, sir.
Obesity. Yes, please.
I'm somehow lost there somewhere. I didn't get it clearly.
What's your name?
I'm Nina.
Yes.
I wanted to, on the slide of the swelling, I didn't understand the point of the origin.
So, do you have some?
Oh, okay.
You don't know? Okay, let me give you a very simple example. Have you ever seen an inguinal swelling?
No.
You have not yet seen it. So for inguinal swelling, do you know inguinal hernia?
Yes, I've heard of it.
You have heard of it. So I'm going to give you a simple example. For hernias, hernia means it's a protrusion of contents of a cavity outside that cavity. That means, taking an example of the inguinal hernia means there is a protrusion of the abdominal contents through the inguinal canal. That means if you have a mass which is moving from the internal ring of the inguinal canal through the external ring of the inguinal canal, that mass is moving. It has an origin and it has migrated to another origin, which means if the mass is getting incarcerated or strangulated, that means the mass has moved from one position to another position. That's one simple example. Another example, imagine someone who is shot, do you see a gunshot wound, okay? And you have a bullet in the body. That bullet can move. It can move from one origin to another origin. So you need always to determine the origin and the current positioning. There is an entry wound for gunshot wound, and there is an exit wound. And if there is no exit wound, it means the bullet or the foreign body is still inside. Do you get it now clearly?
Yes, thank you.
Good. You are welcome, Nina. So the key points in examining, for the general examination, ask yourself, does this patient look well? Examine patients in a warm, well-lit environment. Develop a systematic routine for your examination to avoid missing anything. Abnormalities in the hands and tongue can often indicate a diagnosis. Localized lymphadenopathies could suggest local or metastatic diseases, and use always a systematic approach to examine a lump or a swelling. Other key points, the BMI is important for the prognosis and risk factors for cardiovascular disease. Unplanned weight loss is often important and requires thorough investigations. Edema due to inflammation is tender. Edema due to acute allergy is non-painful. Always measure the body temperature to avoid missing hypothermia or hyperthermia, and the axillary temperature may not be a reliable site for measuring the temperature. Any question here? Okay, I have a question to Christian. Christian, can you hear me?
Excuse me, sir.
Okay.
Yes, please go ahead with the question first.
Yes, so you said
What's
the
your name?
axillary temperature may not.
What's your name?
Tina.
Nina?
No, Tina. Tina.
Tina, okay.
So it says the axillary temperature may not be a reliable site for measuring temperature. So what is right? And then why is it that even till today, sometimes if you go to the hospital, they still take axillary temperature? Thank you.
Okay, have you done in physics?
Yes.
Do you remember the convection, the conduction of temperature, of heat?
Yes, I think so. Yes,
Okay.
somehow.
So what we need to determine a body temperature is the temperature of inside the body, not outside the body. Okay. So the best location for temperature taking is the mouth or the anus.
Okay.
Okay.
Thank
It's not the axilla. It's the mouth or the anus. But as you receive many patients in consultations, you cannot put your thermometer in all patients' mouths or all patient anuses. You cannot. That's why at least we try to use another covered environment, which is the axilla, because what we need is to take the temperature of the body for a mostly closed area, and the axilla is somehow closed. Do you see when you flex your arm to the chest? It's
Yes,
like
sir.
you have closed. It's like you have closed the body of the arm towards the chest. That is where you can take easily the body temperature, but it's not the best. The best where to examine to do a body temperature is the mouth or the anus. That's why in babies who are very sick, when we want to get a temperature, every patient would have their thermometers, you put it in the anus or you put it in the mouth. Okay?
Thank you, sir.
Great. So now I have a question to Christian. Christian, can you hear me?
Yes, actually.
Tell me someone who is in your class, one of your colleagues. Give me a name of your colleague.
Teofil.
Sorry?
Teofil.
Teofil. Is Teofil online? Teofil, are you online? Okay, Teofil is not online. Christian, give me another name, a lady, except Tina and Nina.
Okay, I can take Lydia.
Lydia. Is Lydia online? Lydia? Lydia, can you hear me?
Yes, sir.
Okay, Lydia, I have a question for you.
Okay.
You are in a consultation room. You receive a patient who comes in front of you, and the patient does not sit on a chair. What do you think about that?
Why?
The patient is talking to you. What do you think about that?
I can tell him to sit down.
They insist they don't want to sit.
I can tell him, okay. And I consult him when standing.
So what do you think the patient has? Even before you start asking questions.
Problem on his or okay. He may have a problem causing him not to sit.
Which problem? That's my question.
Maybe a problem on his buttocks.
Like? Give me an example of a problem of the buttock which can prevent the patient to sit. Lydia? Okay, can someone help her?
Wound.
A wound or an abscess or a hemorrhoid. Okay? So the patient can be anxious. You know, when a patient is anxious or a patient has a mental disease or psychological or emotional problem, they may refuse to sit. So that's a very simple example of recognizing a patient's problem even without asking a question, just by observing. Okay? Good. Let's now start the GI examination. When you are examining the GI, you need to know the anatomy. From the esophagus, the mouth, up to the anus, going through the guts. These are important when you're examining a patient. The abdomen can be divided into 9 regions by the intersection of imaginary planes, 2 horizontal, vertical imaginary lines to make regions. These are very important to know when you're examining a patient. You have the right, how do you call this? Right hypochondrium here.
Epigastrium.
Yes, this one. The left hypochondrium, the right flank, the umbilical region, the left flank, right inguinal fossa, the high. What is this?
Hypogastrium.
Hypogastrium and left inguinal fossa. So it's very important to localize the anatomy of these 9 regions because they can help easily recognize what is the problem. Imagine a patient has pain in the right hypochondrium. What do you think is the problem, the possible problem?
The liver, a liver problem.
Liver, what else?
Gallbladder.
Gallbladder, what else? And the chest, right lower or basal chest, okay? So it's very important when you're examining a patient to know these 9 regions because they can help you recognize the disease. The common gastrointestinal symptoms we have in general: anorexia, weight loss, pain, abdominal distension. Anorexia means loss of appetite. Weight loss means there is a significant loss of 3 kg in 6 months. And pain should be either midline, lateralized, in the chest, in the abdomen, and the pelvis. And for abdominal distension, you have to, it is a well localized or it is general abdominal distension. So for the upper GI, you have xerostomia, you have halitosis, you have painful lips, tongue, and mouth, you have dysphagia and regurgitation. What is halitosis? Halitosis is a bad breath due to problems in the mouth or in the guts. They can be from dental, from infection, or from some esophageal disease conditions. Dysphagia means there is difficulties to swallow. There is another term, odynophagia. Odynophagia means pain on swallowing. And regurgitation, it's a bringing up of swallow to the mouth. Mute microphones, please. So these are very important terms that you need to read and you need to know, because this will be the exam question about the terms. So dysgeusia means after taste sensation. Cacageusia means full taste sensation. Globus means sensation of a lump in the throat. Odynophagia, I said it's the pain on swallowing. Heartburn means burning retrosternal discomfort radiating upward. Water brush means sudden appearance of excessive saliva in the mouth. Dyspepsia is non-specific epigastric discomfort. It's a premature fullness during feeding. Nausea, it's a feeling of sick, wanting uttered blood, and heat, the persistent cough depression, which is disorder. So, flatulence, please can you mute your microphones? Mute your microphones, please. So wind and flatulence, we have an excessive offensive gas. Bloating means tension. Hematuria means rectal bleeding. Anismus or dyschezia means difficulty emptying the rectum despite prolonged straining. Tenesmus, it's a persistent urge to empty the rectum with the feeling of incomplete evacuation. And melena means teary stools indicating bleeding from the upper tract. All these terminologies, you need to know them. You have to read them, memorize them, because you are going to need them in the future. Then jaundice or icterus, it's a yellowish discoloration of the skin and sclera. Itching or pruritus is an uncomfortable condition that causes a generalized desire to scratch the skin. So coming now to the abdominal pain. When you have a pain upward, midward, and downward, you need to differentiate exactly the level of pain. If you remember in embryology, we have three components, one called the foregut, the midgut, and the hindgut. The foregut is the pain raised to the epigastrium area. Where is the level of foregut? Can someone remind me the foregut? Someone remind me the foregut?
Yeah, I can try.
Please.
Embryologically, the foregut is a part of the stomatodeum of the of the mouth, descending to the stomach up to the first part of the duodenum.
First part of the duodenum. Which part of the duodenum? D1, D2, or D3? Which part?
Up to the up to 3.
Is 3, correct. And what is the midgut?
You start from this into the become ascending transverse, ascending the large coral and up to the transverse colon.
Up to the transverse. Okay, 2/3 proximal to the transverse colon. Okay. And what is the hindgut?
The hindgut, you move from the ascending of the transverse colon descending to the descending colon, attached to the sigmoid colon up to the anocan.
Okay, so how do you think is the difference between these? What do you think is the major difference factor? Which major difference between these 3 parts?
Okay. They have the different ambulatory origin. I think even the tissue and way of distribution of the factors is different.
Okay, what else? There is another very important difference.
Another difference is in blood supply.
Great, excellent. That's what I wanted to hear. So what is the blood supply of the foregut?
So, I mean, the difference is that is according to the nerve supply and the.
Yes, I got the blood supply. It's the most important. What is the blood supply of the foregut?
Gut is supplied by celiac trunk.
The celiac trunk. Gut.
Superior artery.
And for the midgut?
Inferior mesenteric.
Excellent. So for those who are going to do surgery or general surgery, especially, you will see the big difference between these anatomical positions, because operating a patient in the foregut is different from operating a patient in the midgut, and very different for operating a patient in the hindgut. I hope you will be very curious when you are going to start your clerkship, but it's very important to differentiate these organs and these positionings. And when we come to our subject of abdominal pain, also the pain is different. Coming from the hindgut, the midgut, and foregut, they differ due to the innervation. Some of your colleagues also mentioned about innervation. The innervation of these 3 is also different because of the location of the nerves and the pain irradiation. So the pain from the hindgut is irradiated in the lower abdomen, and the pain through the midgut will be localized in the perium. And the pain in the foregut will be localized in the epigastrium. This is very important to note when you are going to start your clinical clerkship. So for analyzing abdominal pain, remember we used our mnemonics about the site, the onset, the character radiation, timing, frequency, special times, duration, exacerbating, relying, severity. I want you to memorize this table, because this table is something very important you're going to need when you are examining the abdomen. And when you are examining the bear in mind the differentials, starting from the epigastrium, going to the right atrium, going to the umbilical region, and going down into the right or left flank. These are very important to know and very important to. I leave you so that you are going to read it. I will share with you the PowerPoint and the teaching materials so that we can go through all these analyzing of abdominal pain. It also comes to the non-alimentary causes of abdominal pain, which are irradiating. It's very important that the pain in the abdomen is not always localized in the abdomen. It can also come from far and irradiating into the abdomen. So these are important conditions you're going to read later on. And when you are examining the abdomen, the sequence of examination is very important through the inspection, the auscultation, the percussion, the palpation, and finally, you should never forget to do a digitorectal examination. A digitorectal examination shows that you have completed your examination. So if you don't do a DRE, you have not done your examination. Okay? That is mandatory and you have to do it always.
Excuse me.
Yes, please.
So I got a question about the digitorectal examination.
Mm-hmm.
Hello.
Yes, I'm hearing.
Hello.
Yes, I'm hearing. Go ahead.
So what if a patient, so you said the kind of examination with you digit into rectum of the patient. What if the patient refuses such examination? What can you do as a doctor or as a medical student?
Technically, the patient should not refuse an examination. Do you know why? It's because they came seeking for help. They came seeking for something that they don't have and which is really bothering them. So it goes through the communication. Always bear in mind that when you communicate well with your patients, the patients will trust you, the patient will give you all information you need to treat them. It's about the communication. It's very rare to see a patient refusing to be examined if they came to get examined. It happens that the patient can refuse such a step in the examination. It's okay. You don't need to force. You just tell the patient that you need to do it. If they refuse, it's their right. In that case, use what you have. You cannot force a patient to do something if they don't want. Remember, we said consent. Always should give you the consent to do something. Okay? Now it's up to you for the communication to get it. So for the inspection, you have to examine the patient in good light and warm surroundings. You have to position the patient comfortably in a supine with the head only resting on 1 or 2 pillows to relax the abdominal wall muscles. You have to use extra pillows to support a patient with kyphosis or breathlessness. You have to look at the teeth, tongue, buccal mucosa, and ask about the mouth ulcers. You have to note any smell of alcohol, fetal hepaticus, uremia, melena, or ketones. You need to expose the abdomen from the xiphoid to the sternum until the symphysis pubis, leaving the chest and legs are covered. So expose only what you need to expose, and always inform and communicate with the patient of what you are going to do or what you want to do. So the normal appearance, the abdomen is normally flat or slightly scaphoid and symmetrical. At rest, respiration is principally diaphragmatic. The abdominal wall moves out and the liver, spleen, and kidneys move downwards during expiration. The umbilicus is usually inverted. The normal liver is identified as an area of dullness to percussion over the right anterior chest between the 5th rib and the costal margin. The spleen is felt dull in the left posterior aspect between the 9th and 11th rib. So on inspection, you have to look at the respiratory movements. You have to look at any scar, any distension, any striae, visible peristalsis, caput medusae, surgical stomas, and you have to also look at any typical sign like gray Turner or Cullen's. Gray Turner, it's an ecchymosis around the umbilicus, and you have to look for any ectopic pregnancy rupture and any aneurysmal aorta rupture. Those will manifest with abdominal wall ecchymosis. So on auscultation, you have to look for bowel sounds, arterial bruits, and succession splash. For the bowel sounds, usually they are held above 10 seconds, but the frequency varies. So if they are absent, it's in favor of paralytic layers or any infectious condition in the abdomen. If they are increased and the volume and they are pitched, this is in favor of intestinal obstruction. For arterial bruit, you have to look for aneurysmal aorta, renal artery stenosis, and in case of succession splash, it sounds like half-filled water bottle being shaken and delayed gastric emptying. So for percussion, you need to look for dullness if there is free fluid in the abdomen, or hyperoxenus or tympanism if there is a gas filled in the hollow viscous organs. So this is an example of typical examination of the abdomen. And on palpation, you have to use your fingers, either the tips or the palm. And on percussion, you don't percuss on directly on the abdomen. It's better to always support your percussion on the hand, using the left hand, and percuss with the right hand. That is going to give you the sound of the abdomen. So on palpation, you have to ensure that your hands are warm. You ask the patient to show you where the pain is and to report any tenderness elicited during palpation. You have to ask the patient to place the arms by the sides to help relax the abdominal wall. You have to use your right hand, keeping it flat in contact with the abdominal wall. You observe the patient's face for any sign of discomfort, pain throughout the examination, and always begin with the light superficial palpation away from any site of pain. So you have to palpate each region in turn, then repeat during the deeper palpation, and then test abdominal muscle tone by light dipping movements with your fingers. So when examining the abdominal wall, you have to measure the liver edge, which should be felt below the right costal margin. You can feel the aorta, maybe with pulsatile movements. You can feel the lower pole of the right kidney in the right flank. You can feel fecal scabula in the sigmoid colon in the left iliac fossa, and a full bladder arising out of the pelvis may be also palpable in suprapubic region. So some abnormal findings that you need to know, and these are going to be questions in the exam: what is a Murphy sign, what is a Rovsing sign, and what is a iliopsoas? These are tenderness on palpation. The Murphy sign is tenderness at the right hypochondrium when you are asking the patient to have a deep inspiration, and this is in favor of cholecystitis. The Rovsing sign is tenderness on deep palpation on the left inguinal fossa with abrupt release, and pain is felt on the right inguinal fossa. Iliopsoas, it's a pain when you have flexion of the thigh to the abdomen, and this is in favor of appendicitis. So you have also to look for a voluntary guarding, involuntary guarding, any palpable mass, any enlarged organ, and the Courvoyer's law. So the sequence and precautions during the digital rectal examination, you have to explain what you are going to do and ask for permission to proceed. Someone asked me if the patient refused, you have to explain clearly the examination, which might be uncomfortable, but should not be technically painful. You have to position the patient in the left lateral position with the buttocks at the edge of the heels clear of the perineum. You put on gloves and examine the perianal skin using an effective light source and looking for evidence of skin lesions, external hemorrhoids, and fistulas. You have to lubricate your index finger with water-based gel. You place the palm of the forefinger on the anal margin, and with steady pressure on the sphincter, push your finger gently through the anal canal into the rectum. This is a very uncomfortable examination, but with experience, you're going to know that whenever you examine the abdomen, you have always to examine also the digital rectum. So this is the position I was describing to examine the digital rectal exam. There are some of doctors who examine the rectum in a supine position. That's really uncomfortable. In a left lateral position, it's better because the patient feels more comfortable. So if there are anospasms encountered, ask the patient to breathe in deeply and relax. If the patient squeeze your finger with the anal muscles and not any weakness on the sphincter contraction. You have to palpate systematically around the entire rectum, not any abnormality, and examine any mass. You have to identify the uterine cervix in women and the prostate in men. Assess the size and shape and consistency of the prostate and not any tenderness. If the rectum contains feces and you are in doubt about palpable masses, repeat the examination after the patient has defecated. Slowly withdraw your finger and examine the finger for stool color and the presence of blood or mucus. This is how you examine gently the rectum. You palpate first, then you put your finger inside, you examine the anterior wall of the rectum, you examine the posterior wall of the rectum. For ladies, you are going to palpate, you are feeling the cervix. For men, you are feeling the prostate, which is somewhere localized here. And before you do a digital rectal exam for men, if needed, you can also do a digital vaginal examination. So for ladies, where you think you are suspecting a vaginal infection or any condition which is related to the vagina, please do not examine the rectum and then go to the vagina. You're going to contaminate the vagina with rectal flora. So you start with a digital vaginal examination, then you examine the rectum, not the opposite, okay? Good. So for abnormal findings during the digital rectal exam, we encounter hemorrhoids, cancer of the lower rectum, retroalized tenderness can suggest pelvic peritonitis. You can feel a BPH, benign prostatic hyperplasia. You can feel prostate mass, and tenderness plus change in the consistency of the prostate may be due to prostatitis or prostatic abscess, and the prostate is usually abnormally small in hypogonadism. So investigations of the GI and hepatobiliary, they are commonly the radiography, a chest X-ray or abdominal X-ray, a barium meal, a large bowel barium enema or CT colonography, and a abdominal or ultrasound. So I have a question to Lydia. Can you hear me? Lydia, can you hear me?
Yes, sir.
So what's the difference between barium meal and barium swallow? Do you know barium swallow?
No.
Do you know barium meal? Do you know barium meal?
Sure.
So barium meal is the same as barium swallow. So we take a barium, which is a contrast product, and you make the patient drink it, and you take a radiography of the chest and abdomen during the swallowing of that contrast product. When you take a radiography of that contrast product, you can see easily if there is any obstruction through the esophagus up to the stomach. And for any condition which is obstructing, which has a malformation, is going to be well visualized on radiography. Okay? Do you get now the exam? What is the exam?
Yes.
Great. So then barium enema is when you take the same product, but the patient does not swallow it. You put it through the anus and you inflate that contrast product. Then you take a radiography of the colon. That is going to show you any condition, any obstruction in the large bowel and sometimes in the small bowel. Okay? So these investigations are going to help you to get indications or differentials about all these diseases. So I want you to look at this table later on and see what the abdominal ultrasound can give you when you're looking into the abdomen. So there are also endoscopy, either upper GI endoscopy or lower GI endoscopy. There is what we call endoscopic retrograde cholangiopancreatography. This shows an obstruction through the biliary tree. Either it can be an obstructive jaundice or an acute or chronic pancreatitis due to a gallstone obstruction. This exam can be diagnostic or therapeutic, and it can have a role of stenting if there is any stricture or any stone incorporated inside. So laparoscopy is like a procedure where we bring a camera in the abdomen and examine the abdominal cavity. So for the liver biopsy, we use just a big needle and take a tissue biopsy from either percutaneous, or we can do it through laparoscopic route. So this is an example of a, what is this, Christian?
Which one lecture?
Sorry?
Seeing it. I'm seeing the meniscus on under the diaphragm.
I asked, what is this?
Okay. It's an X-ray of the chest.
Yes, this is a chest X-ray. So you have always to know to answer the correct question. When they ask you what is this, you just say this is a chest X-ray. If they ask what do you see on this X-ray, then you can go through and interpret the chest X-ray. Okay? So today we are not learning how to interpret a chest X-ray, but I can show you the abnormality here, which is the air under the diaphragm. This is not a normal process. And what is the condition that can cause air under diaphragm? What is the condition that can cause air under diaphragm? Can you hear me?
Yes.
What is the condition that can cause air under diaphragm?
Probably COVID.
COVID. What's your name?
Nina.
Nina, how can you explain COVID with air under diaphragm?
I think because it is a disease of the respiratory system. So and the diaphragm is part of respiratory So I was thinking if it
Under the diaphragm or above the diaphragm? Do you think it's in the chest or in the abdomen?
in the chest.
Do you think this AI is in the chest?
No.
Where is it?
It has gone in the abdomen.
In the abdomen. Can someone help her and tell us what is the condition that can cause AI under diaphragm?
Maybe the liver dislocation.
Liver dislocation?
Or infra-abdominal infection.
Sorry?
Yeah, abdominal infections.
Abdominal infection?
Yeah.
How can you explain or relate the abdominal infection and the AI under diaphragm?
For me, what I expect, maybe it is like a esophageal or truncoesophageal fistula, which may lead the air to pass within the esophagus and reach into the stomach.
Okay. Someone else?
I think maybe intestinal.
Okay, I think it is a perforation of diaphragm.
Okay. So your answers are both wrong. They are not correct.
Excuse me.
Yes.
Can I add something?
Yes, please. What's your name?
Akeline.
Akeline.
Yeah, I think if someone has the air in the peritoneal cavity, it can cause the air under the diaphragm.
Okay. Now tell me how you can have air in the peritoneal cavity. Do you usually have air in the peritoneal cavity?
No, there's a fluid, and if like there's an inflammation or a disease like pneumonia, something like that, which can cause the air to flow through the peritoneal cavity.
Stop. You started correctly, but then you messed up. Okay. So yes, please.
Can we also say about once the peritoneal fluid is absent in the peritoneal cavity due to maybe different infections, diseases, or the abnormal absorption of the peritoneal fluid?
Okay, it's not correct. So
Excuse me. Okay, I think also perforation of spleen can cause this problem.
Perforation of the spleen?
Yes.
Okay. So, mute your microphone. So, what are the types of organs we have in the abdominal cavity? Akeline, tell me, what are the types of organs we have in the abdominal cavity?
Excuse me, would you mind repeating again?
What are the types of organs we have in the abdominal cavity?
We have the digestive organs.
I know. What are the types?
The intraperitoneal and the intraperitoneal.
That's the location, correct? I agree. But what are the types of organs we have?
I'm not sure. I don't know.
Okay. Tell me a name of your colleague. One of your colleagues.
Kevin. Tuesday, Kevin.
Kevin. So is Kevin online? Kevin, are you online?
Yes, Victor.
Okay. So Kevin, tell me, what are the types of organs in the abdomen?
The sites.
The types of organs in the abdominal cavity. She mentioned about retroperitoneum and intraperitoneum. I agree. What are the types of organs?
Okay. Is it to list them or telling the types? I'm not getting the question here.
Okay, so there are two types of organs in the abdominal cavity. We have solid organs and we have hollow viscous organs. You get the point? A solid organ to me, it's a compact solid organ which does not have air in its content. And the hollow viscous, it's an organ which has air in its lumen. It means, starting, if you remember the abdomen, it's from the mouth up to the anus. From the mouth, floor of the mouth, you have the pharynx, you have the esophagus, you go into the stomach, you go into the duodenum, you go into the duodenum, you go into the ileum, the large bowel, the rectum, and the anus, correct? That GI has it has air in it because the mouth is open and the anus is open. It means air can go through the mouth up to the anus. There is an entrance, there is an exit. Those organs I cited are what we call the hollow viscous organs. They are opened. They have a lumen inside. They can have air and they can be perforated. And if anytime there is an injury on that organ and there is a perforation of that organ which has air inside it, that air is going to go outside the organ and fill into the abdominal cavity. Do you understand?
Yes.
Which means if there is any perforation or injury of a hollow viscous organ, there is going to be spillage of gas from that organ into the peritoneal cavity, which is the typical example of this air. This air means there is a perforation of a hollow viscous organ. Do you understand me?
Yes, now I got the point.
Yes, so now the second type is what we call solid organs. Solid organs, we have the liver, we have the spleen, we have the pancreas, we have the kidneys. Those organs are solid. There is no lumen inside. There is no air inside. If there is any perforation, any injury to that organ, there will be no air because there is no air at all inside. Do you understand? So if there is an injury to the spleen, there is no gas in the spleen. If there is an injury to the liver, there is no gas in the liver. So air under diaphragm means there is an injury to a hollow viscous organ of the abdomen. And finally, the abdominal cavity does not have air in the normal process. The abdominal cavity, it has a smooth light liquid which allows the organ to slide each other. There is no air in the abdominal cavity. Do you understand me?
Yes, Jake.
Do you all understand Kinyarwanda? There is no one who does not speak Kinyarwanda, I hope, in the class? Do you have someone who does not? You don't understand Kinyarwanda?
Yes.
Okay, so perfect. So what I wanted to tell you is that in the abdominal cavity, there is no air. In the normal abdominal cavity, there is no air. Organs are compact. They are sliding each other, one on each other, which means if there is an injury which is going to cause injury of one organ, either a solid or a hollow viscous, the spillage of the content is going to fill into the abdominal cavity. Do you get the point? So then this is the diaphragm, this is the chest, and this is the abdomen. If you have air under the diaphragm, it means there is air which has now come into the abdominal cavity. Normally, there is no air in the abdominal cavity. So if there is air in the abdominal cavity, it means there is an injury of an organ which normally contains air in its lumen. And that organ is a hollow viscous organ. It can either be stomach, duodenum, jejunum, ileum, or large bowel. That's all. There is nothing else which can cause air in the abdominal cavity. Okay? Perfect. Let's go. What is this? Can someone answer me? What is this?
It is abdominal X-ray.
This is an abdominal X-ray. What are you seeing on this abdominal X-ray? Sorry?
Large bowel.
Maybe.
Are you seeing the large bowel?
Yes.
No, I'm seeing the ileum.
You are seeing the ileum. What's the difference
Yeah.
between large bowel and ileum on an X-ray?
On the large bowel, you see
I'm hearing you.
Can you please?
My question is, what are you seeing on this abdomen? This abdominal X-ray, what are you seeing on it? Okay, these segments of the bowels, we can't be sure if it's the small bowel or large bowel, but what we can see, you see host tray and you see air. Okay, do you see air in this abdomen? So when you are going to start learning interpreting X-rays, they are going to tell you that this is what we call paralytic layers. That means there is air which is entrapped or obstructed into the abdomen. This means we have an abdominal distension. It means we have air filled in these bowel loops. I can't be sure if it is the small bowel or the large bowel, but what I can be sure, this is a condition called paralytic layers. You have air in the bowels. There is no air fluid level. It's only air filled in the loops. Okay. So what is this?
An ultrasound.
This is an ultrasound. What is the ultrasound of? What is the organ which is being ultrasound? Okay, this is an ultrasound of the gallbladder. Okay, an ultrasound of the gallbladder. You see, this is the gallbladder. This is what we call a gallstone. The gallstone that you can see on an ultrasound. What is this? What is this image?
Probably the CT scan.
This is a CT scan. Okay, this is a CT scan and it is showing something. This is the bowels. We have air, we have liquids. This is the inside the abdominal cavity, and this is a large bowel which contains stool and air. So this is a CT scan of the abdomen. So always when you are examining, do not forget to examine the groin. This is the inguinal region, and you see swelling. I remember Tina asked me about the region of masses. This can migrate from an indirect inguinal hernia, a direct inguinal hernia. You have two different masses from this groin. Any question about the GI? Okay.
Yeah.
Any question?
Yes. I just want to ask something about the hiccups.
Yes, please.
This is the condition that usually many of people get, and you want to know the cause and how to protect it. Like, if it is that serious, so that you can take it to the hospital, or it is simple.
Okay, before we go into the cause and treatment, I want you to tell me the physiology of hiccup.
So about the physiology of hiccups,
Yes.
we've seen that it is caused by when the diaphragm has like a problem.
Which problem?
I don't remember.
You don't remember. What's your name? You told me Tina?
Akeline.
Akeline. So Akeline, if you want to be a good doctor, master your physiology.
Yeah.
Do you get me?
Yes.
Yes. You will remember this after 10 years. You will remember that Dr. Byiringiro told me to be a good doctor, you have to master your physiology. Do you know why? It's because the physiology is the foundation of the disease. If you know the normal process of functions, you can know the abnormal processes of those functions. And once you know the abnormal processes of the functions, it's easy to know the treatment of that function. Okay? So hiccups means it's a stimulation and spastic movements of the diaphragm. Those spastic movements of the diaphragm, they are involuntary. They're involuntary because there is stimulation and stimulation of the diaphragm. The causes can be multiple. That is the physiology. The physiology of hiccups, it's an involuntary spastic stimulation of the diaphragm. Okay? So now the causes, they can be either from stimulation of the nerves which is innervating the diaphragm. Which nerve?
Phrenic nerve.
The phrenic nerve. It can be from the stimulation of the gastric, of the stomach. It can either be from trauma or pressure in the abdomen. And there are other causes which can be chemical, like alcohol or tobacco. So it means if you know the cause of that involuntary stimulation of the diaphragm, you can know how to treat it. So for hiccups, usually they are temporary because it's just an involuntary spastic stimulation of the diaphragm. If they are coming from the phrenic nerve, you know the phrenic nerve is tributary from the vagus nerve. And the vagus nerve, it's one of the nerve which is innervating almost all parasympathetic organs and systems in the abdomen. Okay, it's a matter of sensory stimuli, and in that case, it's a matter of getting the patient awake and aware of that stimulation. And most of the time, the sympathetic reflex is going to counteract sympathetic reflex, which is immediately going to release that those spastic movements. The second cause, the second treatment is to give a temporary relaxation of the diaphragm. A temporary relaxation of the diaphragm is to drink something. Once you drink something and you swallow, when you swallow and it comes into the lower esophageal sphincter, when that stimulation to the lower esophageal sphincter, it activates the stimuli, the voluntary stimuli of the diaphragm, which means you're going immediately to counteract those involuntary stimuli which had caused the spastic movement of the diaphragm. Okay? The third treatment is to counteract the gastric effect. That's why we give PPI, we give antihistamines to decrease the acidity in the gas, or to eat something. All those mechanisms can stop the hiccups. If the hiccups delay, there are treatment we can give, and those treatments are just temporary. Okay? Is that clear? Your question?
Yeah, thank you.
Okay, great. Can we proceed? Or we take a break? What do you prefer? Can we go until midday and we take a break at midday? And we take a break at midday?
Go ahead.
Okay, great. So for the musculoskeletal examination, you have always to bear in mind that a joint is formed by a proximal bone, a distal bone, and a compact connection of tissues and fluids which keep the bones connected. And here you have the muscles which are attached to the bones through tendons. You have the ligaments which are attaching the bone to the other part of the bone, and we have some pads or meniscus, and we have the joint space which is filled with synovial fluid. And we have cartilages. It's very important to understand this anatomy before you go through examination of the musculoskeletal. So some questions you may ask are, what is the cause of your pain? Is it a trauma or infection? You have to know which part is affected, the bone, the joint, the tendons, or the muscle. How many joints are involved? One joint implies a monoarthritis. Multiple joints involve oligoarthritis. More than 4, they are polyarthritis. Inflammatory conditions produce pain at rest and on movement, and symptoms are often worse in the morning. Stiffness tends to ease with movement or after a warm bath or shower, and non-inflammatory conditions tend to become more painful with activity and ease with rest. Are the joints affected symmetrically or asymmetrically? This is very important questions when you are dealing with your patients with bones and joint conditions. So you have to ask about the structures surrounding the joints, including the ligaments, the tendons, the tendon sheath, the bursae, muscles, and bone for any complaints. And assessing the musculoskeletal pain, use the mnemonics, Socrates, which is also common in this condition. So to know the referred pain, you can use the dermatome to know exactly where is the pain localized. And the dermatomes, I know you have done it in your anatomy. It's very important to know exactly where is the level of which nerve innervating the which zone, and you need to know exactly which zone and which muscle. So I'm not asking you to memorize this table, but with experience, you're going to know exactly how to examine a patient, especially the neurovascular component examination, which is very important in the musculoskeletal examination. So I will not stay too much into this, but you need to know that for each pain, it has a localized innervation, which should be investigated and identified to know exactly what is the pain cause and the pain location. So for the site of pathology, you need to know about the lumbar spine, the shoulder, the elbow, the hip, and the knees, so that you can easily know exactly where is the perception of that pain. For a patient who is coming and complain of thigh or hip pain, most of the time the pathology is in the knee. And when the patient comes for anterior thigh or knees, the pathology is in the hip. So this is very important to interpret a perception. A perception means what the patient feels and the site of pathology. So for this location of motor examination, you know exactly the movement of the parts, abduction, adduction, flexion, extension, and rotation. So these movements are very important to know, and the nerve root which are concerned should be also identified when you are doing your physical examination. So for the muscle power assessment, there is a 5 power score. 5 is normal power, muscle movement. 4, it means the movement are weaker than normal but possible against resistance. 3 means possible against resistance but possible against gravity. Means there is no movement against gravity. 1, there is visible contraction but no movement at all. 0, it means there is no active contraction at all. And at this level of 0 is when we can call the muscle paralytic. So the muscle compartment syndrome is one of the conditions, the disease condition, where there is an increase of pressure in a muscular compartment that exceeds the pressure within the capillaries. This syndrome occurs when the pressure within a closed osteofacial muscle compartment rises above the muscle perfusion pressure and so deprives the muscle of oxygen, causing ischemia and necrosis. So the signs, we have pain disproportionately greater than expected. We have a pale change of color. We have perish cold poikilothermia. There is cold extremity. We have absence of pulses. We have paresthesia. Paresthesia means there is absence of neurosensitivity. And paralysis means there is absence of movements. When you have all these 6 P's, it means you have a compartment syndrome of that limb or organ, and you need to intervene urgently with surgery to decompress that compartment. So this is an example of the forearm compartment. You see all these are muscles of the forearm. This is the posterior. This is the anterior. This is a deep anterior compartment. This is the superior mediolateral anterior compartment, and this is the posterior compartment. So if anytime there is a high pressure in one compartment, the only choice is to come and you open here so that the pressure can be released. If you don't do it, there is progress to necrosis, to ischemia, and further on necrosis with high risk of amputation of the limb. So the compartment syndrome is the true surgical emergency which needs immediate recognition and treatment by fasciotomy to save the limbs, and late diagnosis or inadequate treatment is irreversible. So for late diagnosis or poor management of compartment syndrome is a frequent cause for claims by lawyers for clinical negligence. This is an example of ischemia, swelling, ballet, fluid extravasation with pressure. Do you see pressure which is here with swelling? If you don't release these muscles, I mean these compartments, this hand is going to die. It's now ischemic, it will become necrosis, and later on will die and end up into amputation of the hand. So the management is to come and release this pressure into the forearm. So when we open the forearm, we release this pressure, the leg, we release the pressures, and this is the posterior, and this is the anterior. And when you release the pressure through the anterolateral, it's just to release this compartment pressure in the posterior compartment. So what to do while waiting to start an emergency surgery? Immediately you splint and put a plaster cast completely. This is in case of fracture. You release any tight dressing. You elevate limb to the level of the heart, and you correct any hypoxia, you correct any hypotension, and you administer supplementary oxygen. If you remember, I showed you that limb which was swollen. The only way to release the pressure is to open this compartment. This is a draw. And after opening, you see that we have exposed the muscles which were almost dying. If you don't open this hand is going to, and it will, in all compartment, it shows some muscle is ready. You see the muscle ischemia? And it's very important to recognize compartment syndrome before it ends up into catastrophe. So this is another picture showing the fasciotomy of the leg. You see already that the muscle was ischemic. If you do not open this compartment, the whole leg is going to get ischemic, and necrosis ends up into amputation. So this is an example of a limb deformity with an open fracture of the distal leg, lower limbs. When there is an open fracture, what we do first is to clean, and the cleaning is very important because it helps to decrease the contamination into the wound. Then we proceed with the standard management of open fracture. So this is an example of a closed fracture. Do you see the fracture here? These are the long leg bones, the tibia and fibula. You see a fracture, and you see a dislocation. So this dislocation with the fracture of the fibula is what has caused this problem. So in this case, you have to examine well the patient, you examine the neurovascular components, you examine the motor activities, and you stabilize by immobilizing and reduce this fracture and put on a cast. So for the joint examination, there are 3 ways. You have to look, you have to feel, and you have to move. For looking, you look at the skin, color, scars, rashes, the shape, if there is any swelling, bony or soft tissue, or deformity, or muscle wasting. Position, you look at the deformity. Feel, you have to look at to feel the soft tissues, if there is any swelling, if there is any undulation or tenderness. You have to feel the temperature, and you have to feel the tenderness of the bones and the joints. For movements, you have always to examine active movements is what the patient can do, and passive movements is what you can do to the patient, but the patient can't do. Abnormal movements, it's for example, we have an increased anterior-posterior movement at the knee due to the cruciate ligament rupture. So that means there are movements which are usually in a normal condition not possible, but when those movements are possible, it means those are abnormal movements. So you have to measure the angles of movements. This is a neutral position of the leg. You have flexion, extension, you have dorsiflexion, and plantar flexion. It's very important to know the terms used with those examinations. So the goniometer is the one which is calculating the angle of movements of the joints. This is the goniometer, which can measure the angle of movements. Okay. So in case of fracture, based on the history with high suspicion of fracture, you confirm the diagnosis by radiography or CT scan. You have to respect the rule of 2 to make a diagnosis of fractures and manage them. 2 views, 2 joints, 2 times, 2 limbs to compare, especially in children. 2 views means profile and lateral. 2 joints means proximal and distal joint. 2 times means before and after any action. 2 limbs means right and left if you want to compare the ones which is fractured and the other one which is not fractured. So for the spine examination, you have to stand behind the patient and assess the straightness of the spine, muscle bulk, and symmetry in the legs and trunk. You have to look for any asymmetry at the level of the iliac crest, unilateral leg shortening, and swelling or other abnormality of the gluteal, hamstring, popliteal, and calf muscles. You have to look also at the Achilles tendons and hindfoot regions for swelling or deformity. You have to stand beside the patient and ask them to bend down and try to touch the toes. This highlights any abnormal spinal curvature or limited extension of the hips. And you have to stand behind the patient, hold the pelvis, and ask to turn from side to side without moving the feet. This tests mainly thoracolumbar rotation. And you have to ask to slide the hand down to the leg towards the knee and stand in front of the patient and ask to put the ear on the shoulder to test lateral cervical flexions, and this tests lateral lumbar flexion. So these are the movements I was saying, the bend down, lateral flexion of the neck to see if there are lateral movement of the cervical spine. And you don't forget to regular the patient to look it on the back to examine well the thoracolumbar and the sacrum. So now we are going to see a trauma patient examination and the management. So there is what we call the primary survey, which is the management of the systematic management of a trauma patient. Here to do a rapid sequential look. It takes 2 to 5 minutes. You have to treat as you find. You find, treat it. You find the problem, you treat it, and you repeat anytime once it is unstable. The primary survey is made by what you know as ABCDE. ABCDE approach has now been approached with a C, which is mostly done in the military. In the military, we start first a massive catastrophic, we call it ABCDE. It means if you reach a patient who has a trauma, you immediately control the massive catastrophic, otherwise the patient will be exsanguinated. Then on A, control the airway plus cervical spine mobilization. You put a C-collar, you control the airway. On B, you look at the vitals, the oxygenation and ventilation. On C, you look at the circulation, BP, the heart rate, the vascularization. On D, you look at the mental status of the patient with a Glasgow Coma scale, and exposure, you look for any wound which is involved in that trauma patient. So airway, you have to look, listen, and feel. Look for colors if the patient is cyanotic, consciousness state, or accessory muscle movement use. So does this patient have an airway problem? That's a question to you. Can you ask me? Can you answer me? Does this patient have an airway problem? Akeline, can you answer me?
Yes.
Does this patient have an airway problem?
I can say yes.
How?
By looking, like the airways, the nostrils are somehow, I can say, the nose. If we can, if we is asked to inhale through the nose and the blood has went to the nose, then this patient probably about the inhalation and exhalation can be difficult for him.
So this patient has an airway problem because we have blocked him to breathe through the mouth because of this Minerva of this collar, C-collar, and he's having bleeding or fluid or blood through the nose, which means he cannot breathe in the mouth because it is blocked, and he cannot breathe through the noses because there is blood through the noses. So this problem has surely an airway problem. The second attempt, we think possibly he's unconscious. If the patient is unconscious, most of the time they can't control the airway. So when you look at the airway, you have to look at the color, respiratory distress, conscious status, the chest movement, You have to listen for breath sounds and the feel. It's a very simple assessment way is to talk to the patient. Once patient can talk, they can express a voice. It means most of the time the airway is open. For the signs of obstruction, there is a snoring or gargling, stridor, agitation, paradoxical chest movement, and cyanosis. So the airway management, number one, we do a chest lift or jaw thrust. Adjunct, we can put oropharyngeal airway or nasopharyngeal airway. For advanced techniques, we can intubate the patient either through endotracheal or we do a surgical cricothyroidotomy. So this is what we call a chin lift. A chin lift means you try to open the mouth by lifting the chin. A jaw thrust means you take through the jaw and you elevate those jaw. We call them jaw thrust because this is going to help elevate the oropharynx, which will open the oral airway. Adjunct techniques is just to put a Geda cannula. This is to keep the mouth open and the patient is going to breathe through this opening, or intubate the patient by using this endotracheal tube. You see the endotracheal tube which goes through the trachea, or we do a surgical cricothyroidotomy by opening through the cricothyroid cartilage, and this is done in case there is a difficult intubation which failed and the patient needs to be intubated. You see this patient is cyanotic. Do you see cyanosis? The patient has come blue. If the patient has come blue and cannot intubate, you immediately have to create another surgical airway. This is what we call a cricothyroidotomy. Even the needle may be enough to save the patient because they can breathe temporarily. This is the thyroid notch. This is the thyroid notch. This is the cricoid cartilage. You go in between the thyroid cartilage and the cricoid cartilage, what we call the cricothyroidotomy space, and you put either a needle or you can even incise and make an opening to let the patient breathe. So for breathing, it's a second priority in establishment of effective breathing. You have to look counter-respiratory rate. Are any of the following present? Cyanosis, penetrating injury, presence of flail chest, sucking chest wound, or use of accessory muscles. You have to feel the trachea shift, to feel any broken ribs, the chest wall expansion on both sides of the chest, or subcutaneous emphysema. You have to also do percussion, which is useful for diagnosis of hemothorax or pneumothorax. You have to listen with a stethoscope to diagnose any pneumothorax or hemothorax, which have decreased breath sounds on the site of the injury. You have to detect abnormal sounds in the chest, and the management, you give oxygen, you assist ventilation with mechanical ventilation. You immediately decompress tension pneumothorax, and you drain hemothorax or pneumothorax with a chest tube. On C, circulation, the objective is to understand the structured approach to circulation problems and recognize and manage a shock. This is the third priority in trauma patient, which has to establish a good circulation. Hemorrhage is responsible for about 1/3 of in-hospital deaths to trauma. The shock is defined as inadequate organ perfusion and tissue oxygenation. In the trauma patient, shock is most often due to the hemorrhage and hypovolemia. Shock is a clinical diagnosis, and it is most important to identify the cause. It is based on assessment of the clinical findings of tachycardia, capillary refill time, hypotension, tachypnea, decreased urine output, and changes in mental state. The treatment principles in hemorrhagic shock are to stop, number one is to stop the bleeding, to replace the blood loss, and the goal is to restore the blood and oxygen flow to the vital organs by the administration of fluid and blood to replace the intravascular volume lost. So the steps, you put a large bore IV line, you take blood for cross-match and laboratory tests. Your first line infusion fluids are crystalloids. and blood loss of more than 10% of blood volume should be prompting blood loss, which will require blood transfusion. So I have a question to to you. What do you think is the total volume of blood in a body, in someone? Can someone answer me? What do you think is the total volume of blood in your body?
It's in a range of 4 to 5 liters, but it varies for male and female.
Excuse me, come again?
I said from like 4 to 5 liters, but for male it's like 5 liters and slightly above, but for females.
How do you calculate it?
I'm not really sure.
How do you calculate the total volume of your blood?
I'm not really sure about that.
Anyone can help?
They say, like for most people, it's 10% of their body weight.
Can someone else help? Anyone else?
Let's just help.
What is
My name is
total blood?
Adrien.
Yes. Yes, Adrien, tell me.
I think it is 80% of the human body weight.
How do you know it's 80%? How do you know it's 80%?
It is from some research.
Okay, what's your name?
Adrien.
Adrien, what is your weight in kg?
I'm not sure, but
Just
it's about
estimation.
60 kilograms.
60 kg. What do you think is your total volume of blood?
80%.
Calculate it and tell me. 80% of kg or 60? What do you think is your total volume of blood? You told me you weigh 60 kg, correct?
Yes.
What do you think is your total volume of blood in liters?
Let's just calculate. Let's calculate 4.8 liters.
How did you calculate 4.8 liters?
Take 60 kilograms. 60 kilogram times 60.
Okay, give me a name of your colleague. Your best friend, classmate. Who is your best friend, classmate?
Best friend.
Adrien.
Doris.
Adrien. Can you hear me?
I only mentioned Doris.
Doris. Okay. Doris, are you online?
Yes.
Doris, are you online? So, what do you think is your weight? Estimate.
My weight is 72 kilograms.
72 kilograms.
72.
Okay. What do you think is your total volume of blood?
I suppose that maybe it's like 60 liter.
How did you calculate 60 liters?
No, I imagine according to the weight.
How do you imagine that? I want the reasoning. How did you come up to 6 liters compared to your weight?
They say that to calculate them, you take your weight and you divide by you multiply by your weight and you divide by 100.
Okay. Do you have a classmate who have a child?
Yes. No.
You don't have any lady who
has what?
A child.
No, in class all we are single.
Yes, you're single. Okay, so my question is, just tell me, have you seen a child? Any child you have seen? Any newborn? Let's take an example of a newborn, okay?
Yes.
Let's take an example of a newborn of 2 kg. No,
yes.
2 is too low. Let's take 4 kg.
4 kg. Yes.
What do you think is the total volume of a 4 kg newborn?
Yes. For that child who has 4 kilograms.
Yes.
Yes. It has 0.32 liter of blood.
0.32 liters. That means 350 mils.
Yes.
How did you calculate it?
Yes, I have calculated in the phone.
In the phone. How did you calculate it? I want the formula you used.
I take the 4 kilogram times 8 over 100.
Do you know the height of the child?
No, 8. The number
8. Number 8.
Yes, the number 8. I multiply the 8 by the 4 kilogram and I divide by 100.
Okay, so it's not correct. The formula for calculating the total volume of blood is 80 mils per kg. You get me?
No.
Yes.
So it means not 80, 70 mils per kg. So 70 mils per kg means for a 4 kg newborn, the total volume of blood is only 280 mils, regardless of the age or regardless of the height. Okay? So the formula for total blood volume is 70 per kg, 70 mils per kg, which means for you who is weighing 72 kg, you have around 5 liters of blood. Do you get me?
No.
Yes.
The total blood volume of a person is 70 mils per kg. Do you get me?
Yes.
So which means if you, it's a formula. It's a formula you need to memorize. Do you get me? The total blood volume of a person is is 70 mils per kg. Meaning, if you weigh 60 kg, you have a total blood volume of 4.2 liters of blood. If you weigh 50 kg, you have a total of 3.5 liters of blood in your body. You get me?
Sorry, teacher.
Okay.
How is it calculated? How is it calculated?
It's a formula. It's a formula which was calculated with physics, and we end up with 70 mils per kg. That's the total volume of blood. Meaning a newborn who has only 2 kg is having 140 mils of blood. Do you get me? Someone asked the question. Please bring the question.
Question, Prof.
Yes.
Is there any difference between male and female?
No, there is no difference. Why? Why there is no difference in terms of blood volume?
Because there is some formula which say that about female you have to calculate by using 65 milliliter per kg.
That's when you are calculating the liquid, not blood volume. You are talking about liquid volume. Water. You mean water volume. The water volume depends on the fat tissues. The difference between men and males is only on fatty tissues. The blood is not in the fatty. Whether you are a man or you are a lady, the vessel is fat. That's why the water volume depends on the proportion of an individual. It depends on the proportion of and the size of the person. But for the blood, it depends only on the vessel system, which means there is no component of gender, no component of age. It's about the kg. It's about the weight only. Okay? Another question?
Yes.
So this is very important to know because it is going to help you estimate the blood loss in a trauma patient. Imagine
suppose someone has 90 kg. What is the blood according to
90 kg times 70? That means 6.3 liters. Is that clear?
I'm not.
The formula is very clear.
Okay.
70 mils per kg. For someone who has 100 kg, it means they have 7 liters of blood. For someone who has 1 kg, it means they have only 70 mils. Do you get me?
I think I can add some small thing. Something which is confusing is dividing by 1,000. It's because
listen to me. There is no dividing by 1,000. We are not talking about proportion. We are talking about the volume of blood, the total volume of blood. You are mixing about water volume and the total body weight, correct? Where you have 60% of the total body which is in water, correct? Here it's a clear formula. The formula says the total blood volume of a person is 70 mils per kg. Regardless if you are kashik, if you are obese, if you are fatty, if you are men or males or the newborn, it's a 70 mils per kg. That's a formula. Do you get me? Where is the confusion then?
Another question.
Okay, give me the question.
Question, Prof.
Yes.
Question.
Yes. I'm hearing. Tell me the question. Go ahead.
Could you allow me to say it in Kinyarwanda so that it may
No
be
problem.
quick?
Yes, please. Go
Yeah.
ahead.
Nabonye benshi mu gihe cyo gutanga amaraso hari igihe usanga umuntu ufite ibiro byinshi ashobora gufetinga kandi wa wundi arusha ibiro byinshi cyane atafetinze, biba byagenze gute?
biba byaturutse ku bintu byinshi cyane. Ibyo bintu byinshi cyane nibyo ntahereho mbabwira. Medicine is a big picture. Ntago umuntu kuba umukuyemo mililitiro 100 bivuga ngo kubera ko abyibushye ntabwo ari bufentinga. Ashobora gufentinga kubera icyo twita orthostatic hypotension. Ntabwo bivuze ngo amaraso wayamumazemo, bivuze ngo uko kumukuramo iyo proportion byagabanyije capacity yarasanganywe. Ikindi cya kabiri gituma umuntu afentinga ubwoba, ibyo bita vagal reflex. Vagal reflex ituruka ku bintu byinshi. Ni kubera ya maraso ubukuyemo ashobora guhita agabanya blood volume agatuma umurwayi itagira vasoconstriction. A vasoconstriction it's a reflex. Ni reflex y'umubiri kubera ko blood igabanutse. Iyo umuntu akomeretse akava amaraso, imitsi yose ita ikora vasoconstriction. Do you get me? So fainting after giving blood, after donating blood, it's a normal process which is not related to the blood given. There are many factors, not only the amount of blood given. Okay?
Thank you.
Good. So now I'm going to ask you a question now. You have a newborn of 2 kg. Do you get me?
Yes.
So that newborn is injured and is bleeding actively. And that newborn has lost, do you see a cup of tea? A cup of coffee? Those small cup of coffees?
Yeah.
And approximately the newborn has lost around 1 cup of coffee. What do you think the newborn has now? Get me?
Yes.
Yeah.
So imagine that newborn with a 2 kg who has lost around 100 mils of blood. What do you think is left in her or him? Reka mbivuge mu Kinyarwanda kugira ngo mubyumve neza. Uruhinja rufite ibiro 2 rurakomeretse, rutakaje amaraso yajya mu gikombe. Igikombe cya mililitiro 100. Urwo ruhinja murumva rumeze gute?
So ubwo ruhinja ruzaba rusigaranye mililitiro 40.
Mililitiro 40 gusa. Urumva percentage y'amaraso rusigaranye ingana gute?
He has 0.04 liters.
No, he has 140 mils of blood, total blood, correct? if that newborn has lost 100 mils, he's only remaining with 40 mils, which means he has lost around 60% of his blood. Get me? So when someone has lost around 60% of blood, we are at this level. Do you see? Do you see the table I'm showing you? These are levels. These are levels of shock. This is the first level of shock. This is the second level of shock. This is the third level of shock, which is really a severe shock. And imagine someone has lost more than 30%. So more than 30% for a kg of 2 for a 2 kg newborn, it means around 20 mils. Correct? Muri kumva 20 mils uko zingana? 20 mils nta nubwo zigiye nta nubwo ari n'igice cy'igikombe, ni munsi y'igice cy'igikombe. Urabona agatase gatoya, 20 mils ni igice cy'agatase gatoya. Uruhinja rufite ibiro bibiri, iyo rurimo kuva amaraso, buri drop ni ikintu kinini cyane kiba kivuyemo. Do you get me? Because that drop counts a lot to the total blood volume of the newborn, which means when you are examining a patient in trauma, you have to consider the blood loss, the percentage of blood lost compared to the total volume of blood of that person. You see me, I get a trauma and I have around 10% of blood loss. 10% of blood loss, I'm in this level. Level 1. Category 1 of shock, hemorrhagic shock. That means my heart rate is below 100, my blood pressure remains normal, my capillary return is normal, respiratory rate is normal, mental status is normal. But once you have lost more than 30%, it's around 1.5 liters. 1.5 liters, the heart rate has increased, the blood pressure is decreased, there is a prolonged capillary return, there is the respiratory rate which is high, and there is a change in mental status. So this is very important to know when you are examining a trauma patient. Always estimate the blood loss, because the blood loss can tell you the category or severity of the shock. Okay? So when you...
Question.
Yes, please.
I'm Anastas. I would like to know, suppose that you are in an accident, how can you determine the blood loss of the patient?
By taking the heart rate, by taking the blood pressure, by taking the capillary return, by taking the respiratory rate, by looking at the mental status of the injured patient. You, on the scene, you see someone who is bleeding, someone who is anxious and confused, make sure that that person has lost more than 30% of the blood volume. This is physiology, my dears. This is physiology. It means if you have lost a lot of blood from your blood volume, the heart is trying to compensate. When the heart is trying to compensate, it increases the speed, it increases the heart rate. Okay? When the heart can no more compensate the vessels, there is a loss of blood pressure. When there is no more blood arriving into the capillaries, there is no blood supply into the capillaries. That's why the capillary return is prolonged. And when there is loss of blood, the lungs try to hyperoxygenating the body. There is hyperventilation. That hyperventilation is caused by loss of blood volume. Do you get me? You may not see or estimate the blood loss with a visual contact on the blood loss, but looking at these signs, the heart rate, the blood pressure, the capillary return, the respiratory rate, and the mental status, you can know which category, and estimating the blood loss. You can estimate the blood loss. Sibyo? Do you get my point? This table is very
Yes.
important. You are going to need it in your career. Every time you're going to treat an injured patient, always remember the heart rate, the capillary turn, the respiratory rate. Ntabwo bisaba machine kugira ngo calculating. You don't need any device. Just with your fingers, you can know the heart rate of a patient. You can know the capillary turn. You can know the respiratory rate. And immediately, by knowing these three factors, you can know which category of the shock of your patient. And by knowing the category of the shock of your patient, can guess what is the blood loss. Do you get me?
Yes.
This is going to be a question of exam to show you the importance of this. Okay? Memorize it well, understand it well. If you have any question, ask me. Good. So now we are having a patient with polytrauma. A polytrauma means the patient has multiple injuries at the same time. This gentleman was involved in a collision, motor vehicle collision, and he sustained head injury, abdominal injury, chest trauma, bilateral open extremity fractures. You see wounds with fractures, and you see the deformity of the lower limb. This is a dislocated hip, possibly a pelvic injury. Okay? Do you see this? This means the patient got multiple trauma. How do you treat this patient? This is another example of a patient who was involved in a stab wound. The patient was involved in a stab wound, and you see a lot of blood which is lost. This is the real. This is the real images we get in the hospitals. So this is a crush open fracture of the foot. You see a crush wound, you see open fractures. This is a trauma of the leg. How do you assess such a patient? Akeline, tell me. How do you approach such a patient? So,
I can start with what is more important.
What is more important?
Yeah, like for this one, no, I can first assess the blood, and if it needs the blood, I start with blood transfusion, then I start with the head.
Continue.
Since I have first I have carried out the exams, the most crucial, like surgery, the most. That is what I can base on. Like, if the abdominal injury is more severe than the head injury, I can start with the abdominal injury, the most severe injury. That's what I can start with.
You know what? Your patient is dead.
Oh.
Yep, you have killed the patient. You are the one who killed the patient.
How?
Because you don't know how to approach a trauma patient. And I just gave, yes, please, tell us how Akeline killed the patient.
So you said it is the CABCD.
Thank you.
We should first see if we can understand like how much blood he has lost. So
yes.
Then after knowing that if he needs a blood transfusion, then we can analyze the other ABCD.
You have also killed the patient. Someone else can help? I want someone who did not talk today. Someone who did not intervene today, please go ahead. Tell me how our colleagues have killed the patient. Shema, can you hear me? Christian, can you hear me?
Yes.
Okay, Christian, tell me how our colleagues have killed our patients.
I'm not sure.
You are not sure. Okay, cite me a colleague, one of your colleague, your best friend, classmate. Tell me, who is he? Give me a name.
Ivo.
Eh?
Ivo.
Von.
Ivo.
Ivo. Okay. Ivo is Ivo online?
I don't know.
You don't know. So, do you remember what we said? Let me come back to the most important slide. This is the most important slide. You receive a trauma patient, you approach this way. If I ask you a question in exam, how do you approach a trauma patient? The answers I want you to give me. You approach a patient using primary survey with A, B, C, D, E approach. Okay? So the C, the first C is for controlling massive bleeding. You stop the bleeding. You don't intervene by giving blood. No, you just stop. If there is a highly active arterial bleeding, you just compress. And after compressing, you do A, B, C, D, E before giving blood. Because if you're going to, you are struggling to give blood, the patient will die from airway obstruction. Do you get me? The most important in a trauma patient is airway control, then breathing, then circulation. So on C as circulation is where you bring blood. But before you bring blood, you have to control the airway. Otherwise, the patient is going to die from airway obstruction. Do you get me? That is how Akeline and his colleague and her colleague has killed the patient. They did not control the airway. They did not apply the C-spine to immobilize the neck. Because if you do not immobilize the neck, the patient is going to get complete paraplegia, complete tetraplegia. On B, you take you look at the respiration. If there is any tensive pneumothorax, if there is any hemothorax, you control it before you go to the last point. Okay? Never be impressed by the wound. Never be impressed by a deformity. Just follow this systematically. Do you get me?
Yes.
Yeah, this is, if you see this slide, it's going to be a question in this year, next year, in your final year, and whenever you're going to be a resident in surgery, you will get this question until you become a doctor, and when you will be a doctor every day. This is going to be your practice question. Trust me. Do you understand? Okay. Ask me any question you want.
Yes. About that food, how can you control that?
Control what?
This primary survey on that food we saw on the image. How can you control it?
This one?
We have seen an image of the food. How can you control that?
This food? You mean this food?
Yes.
I said never be impressed by a wound. This is not the biggest problem this patient has. Do you know why? Because controlling this is very easy. You just apply a garrot. Do you know a garrot? A tourniquet? ufata umugozi cyangwa centure ugafunga ku kaguru kugira ngo amaraso adakomeza gutakara. That's what we called control massive bleeding. Sibyo? So if you receive such a patient with an isolated crush wound of the leg, you first control the bleeding. Controlling the bleeding ni ibintu bifata amasegonda abiri. Ufata umugozi, ufata ikiziriko, ufata centure, ufata umwenda, ukazirika hejuru hari kuva amaraso. Sibyo? That blood flow is going to stop. That takes 2 seconds. Then you go back to the airway. Sibyo? Airway, breathing, circulation, disability, and exposure. Akaba ari ubwo wongera kugaruka ku kirenge. Okay? So this is the last level of management. The first important, control the bleeding, you stop the bleeding, then airway, C-spine mobilization, breathing, circulation, disability, exposure. Ibyo ni ibintu nafashe mu mutwe mu myaka yose maze ndi umuganga. Namwe nicyo nshaka. I want you to memorize it. Anytime you have a junior colleague who is calling you on phone, doctor, what should I do? I have a trauma patient. The first question you ask, how is A, B, C, D, E? When you use A, B, C, D, E, you are being systematic. You see, this patient has, let me come. You see this patient who has a lot of injuries at the same time. This patient can die from any of these injuries. So when you are mixed, you are confused, to be well organized, you need a coordinated approach. So the coordinated approach starts by stopping a massive bleeding, then doing airway, then doing breathing, then doing circulation, then doing disability, then doing exposure. Please, ask your question.
Circulation, disability, and exposure.
Ntabwo turabigeraho. We are still at airway, breathing, and circulation. Disability and exposure, we have not yet reached it.
Oh, I was asking if you can remind us C-spine mobilization.
The C-spine mobilization, you put a C-collar only. Do you remember for airway? You do a chin lift, a jaw thrust, you put a neuro cannula. This is to allow someone to breathe. It's very important to allow someone to breathe. Kuko, tuzabibona muri physiology. I again talk about physiology. Iyo umurwayi agize trauma ntahumeke, ibindi byose wakora biba imfabusa. Kuko if someone is not breathing, whatever you're going to do will be useless because the patient is going to breathe, to not breathe at all. This is going to become acidosis. Metabolic acidosis kills the patient immediately. If the patient has metabolic acidosis, there is really less chance to save that patient. We are going to see it in a few slides before we have a break, okay? So this is how you control the airway. For the for the mobilization, you put a C-collar. You ask me a question, how you control the cervical immobilization, you put a C-collar. If you don't have a C-collar, just use, have you seen the boards that Sami uses? Just keep the head of the patient immobile. That's the most important. Use whatever you have, but prevent any mobility of the head. Because if the patient had a spinal cord injury, a cervical spinal cord injury, there is a high risk for tetraplegia. Tetraplegia means all limbs, lower and upper limbs are going to be paralyzed, and that is irreversible. Do you get the point?
Yes.
Great. So now,
excuse me.
Yes, please.
I've got a question. Is this the primary survey approach applied to all the traumas, or you sometimes you do what is necessary first, an example, let's say you receive an imaging and a person is losing blood, but also has the breathing has stopped. So are you going to control blood first, or you control the breathing?
That's why there is a systematic approach. A, B, C, D, E. You start always with airway, breathing, circulation, disability, exposure. Rwose don't be confused. Nimba uhuye n'umurwayi ufite trauma nyinshi, ntabwo uhera ku kirenge, ntabwo uhera mu nda, ntabwo uhera ku mutwe. Uhera kuri airway, breathing, circulation, disability, exposure. Ibyo mubifate mu mutwe. Ni formule mugomba kunywa. Sibyo?
Thank you.
If you arrive on a scene, there is a patient who has an injury, or there is a stab wound, umuntu bamuteye icyuma mu nda. Sibyo? Abantu barimo kurwana, they are really fighting and someone got stabbed in the abdomen. I know the chest is okay, kubera ko bamuteye icyuma mu nda gusa. Ariko to be systematic, always airway. If it is clear, move to the next one. If it is clear, move to the next one. You have only 2 minutes. Remember, I said, you have 2 minutes to save the patient. Do you see? 2 minutes ugomba kuba warangije gusuzuma umurwayi wawe from head to toe ukoresheje iyi system. I do want you to take bimwe dukora bisanzwe byo gusuzuma umurwayi ngo head to toe examination. No, for a trauma patient you start with airway, breathing, circulation, disability, exposure. Akangaka, this one control massive bleeding kiyongereyeho, because if someone is really having a massive bleeding, understand me, I said massive bleeding. It's not a simple bleeding. Yeah, bleeding, aorta irimo kuva. Do you get me? Aorta or femoral artery. It's really bleeding a lot. You first stop bleeding. Stopping the bleeding does not mean intervene to replace the blood loss. So and stopping the bleeding, even with amasegonda abiri, only 2 seconds to control the massive bleeding. This slide is very important in your management of a trauma patient. Okay?
Yes.
Yes.
Good. Let's continue before we have our break. We are almost done. So now, these are levels where you can lose your blood. A closed femoral fracture can lose up to 2 liters. A closed tibia fracture can lose up to 500 mils. A pelvic fracture can lose up to 3 liters of blood. A rib fracture can lose up 150 mils. In the thorax, hemothorax can produce 2 liters. Hand-sized wound can be 500 mils. Imagine the abdominal cavity. Someone told me who has 72 kgs. How many liters do you have in your blood? As your blood? We said around 5 liters. Correct?
Yes.
Don't you think you can put 5 liters in your abdomen? Don't you think you can put 5 liters in your abdomen?
No.
Why? Your abdomen 70 kg. Your abdomen can take even 10 liters.
Okay, yes, I understand it. It can.
Yes, because it's elastic.
Yes, it can expand.
Yes, it can expand. If your abdomen can expand, it means it can contain your total volume of blood. That's why on the abdominal cavity, we did not mention the blood that can contain. Sivyo?
Yes.
Yes, so that means if someone has an internal abdominal bleeding, an internal abdominal injury, the abdomen contains your total blood volume. Amaraso yawe yose ashobora kugushiramo akajya mu nda, yagushizemo yose. I'm a general surgeon, I know what I'm saying. You can lose your total blood volume and be contained in the abdominal cavity. 6 liters of blood can go into your abdomen. So be careful then when you are examining such a patient, okay? Be very careful. Do you get me? This is it. I like this picture because it shows really the reality on ground, on field, of what you can have. I like the picture. You have someone who has a head injury, abdominal injury, lower limbs injuries, and hip injuries. And from the hip, you can have 3 liters of blood. Sylvia? So now let's talk about the disability. Disability is when you are assessing the mental status of the patient. The mental status, you have the pupils, you have to check the awareness. Awareness means awake, fully awake, only responding to verbal, only responding to pain, only unresponsive. You know this, AVPU, correct? So in trauma, we don't use AVPU. We use what we call the Glasgow Coma Score. The Glasgow Coma Score is assessing the eye opening, the verbal response, the best motor response. And when the patient has a full Glasgow Coma Score, it's up to 15, okay? So now I have a question for you. Imagine, can you hear me?
Yes.
Imagine you have a Chinese who is blind and who is tetraplegic. Do you get me? Let me put the question in Kinyarwanda. I will translate for those who don't understand Kinyarwanda. So ufite umurwayi w'umushinwa. Usanzwe ari impumyi, usanzwe afite pararizi y'amaguru yose n'amaboko yose. Yagize trauma barimuzanye muri ambulance. Akugezeho uri gukorera CHB. Ni wowe muganga uri ku izamu. Glasgow Coma Score y'uwo murwayi uzayibara gute? Tell me, quick. Tell me. I want a lady. I want a voice from a lady. Please. Turimo kurangiza. I know you are tired, but let's finish. So my question was, you receive a Chinese patient who is blind and who is tetraplegic and paralysis the both upper and lower limbs, who got injured in a car, and you want to assess the Glasgow Coma Score. How are we going to do? Please, a lady. I want a lady. Anyone?
I can try.
Yes, please.
The eye opening is none. Then for the verbal, it's a confused talk because you don't speak the same language. And then for the best motor response, I thought because it's both the upper and lower limbs, I used the flexors limb normally to pain and the flexors limb abnormally to pain.
He's paralyzed. He's already paralyzed.
So it's none.
Okay, so you are giving him how much? Only 2 or 3?
60.
You are giving him none on eye opening, none on motor response, and confused on 4, which means he has 6.
Yes.
Okay. Can your colleague help? There is someone who is also going to talk. Please be quick.
For me, how I understand it, if the patient is paralyzed and is blind, the remaining Lascoma score to use is to use the verbal one.
Okay. So I know I always give this example for my students because it's a tricky. And you are wrong always, because this Glasgow Coma score reflects the level of consciousness. Someone who is tetraplegic does not mean he's not conscious. He's fully awake. Someone who is blind does not mean he cannot open the eyes. A blind person can open eyes, does not mean he's going to see. Muri kunyumva? Umuntu w'impumyi afungura amaso, ntabwo abona ariko afungura amaso. Kuba atabona ntabwo bivuze ko adafungura amaso. Do you get my point? Umuntu kuba ari umushinwa akavuga igishinwa cyiwe neza, wowe kuba utacyumva ntabwo bivuze ko ibyo ari kuvuga biri confused. Ahubwo ni wowe uri confused nk'umuganga kuko utumva ibyo avuga. So umuntu rero kuba afite tetraplegia ari paralysis ntabwo bivuze ko atobeyisa akamanzi zawe. Icyo wamusaba gukora yagikora. Uramutse umubwiye ngo sohora ururimi yarusohora. Umubwiye ngo uhindukize umutwe yawuhindukiza. Sibyo? So the Glasgow Coma score assesses the central nervous system. It assesses the CNS. That's why eye opening is localized on the frontal, because it is related. Sorry. It is related to the motricity of the eyelids, not to the visual function. We are not asking if the patient can see. No, we are asking, can you open your eyes? Yes. If the patient does not open eyes spontaneously and you pinch them, they can open eyes on pain. Seeing or not seeing, that's another point. Sivyo? That's the frontal cortex we are examining. For the verbal, we are examining the parietal, the temporal parietal, because it's the level of voice and coordination of idea. Then for the motor response, we are examining the midbrain, above the midbrain. This is the anatomy. The Glasgow Coma score is the anatomy of injury in the brain. So we are assessing the level of consciousness of a patient. So someone who is a Chinese who does not speak your language, it means what you assess is the speech. Muri kunyumva uko mvuga? Iyo umuntu avuga ibintu nubwo waba utabyumva, ariko ushobora kumenya ngo ibintu arimo kuvuga biri coordinated. So a speech means someone who can speak 3 words. Ndimo kuvuga amagambo 3 akurikiranye, arenze 3 akurikiranye. That's a normal speech. Ubu byumva cyangwa utabyumva, icy'ingenzi urabyumva. Umuntu uri confused, a confused talk ni wa muntu uvuga amagambo 2 gusa. Kumva avuze amagambo 2 aracecetse. Kumva arimo kuvuga ibintu asubiramo. Digi. That means that's a confused. Kuba ubyumva cyangwa utabyumva ntabwo bikuraho ko atarimo gushobora guhuza amagambo 2. Noneho umuntu uvuze ijambo ntirisohoke, ukumva avuze ijambo rimwe, nta rya kabiri avuzeho, that's inappropriate word. Ukamubaza ikintu agasubiza ikindi akoresheje ijambo rimwe. Inappropriate sound means even the word cannot come out of the mouth. It's only a sound. And if there is no sound, it means there is none. So someone speaking Chinese, you can assist them even without knowing their language. You don't need to understand a drunk man. You don't need to understand a drunk patient knows they are drunk. Sibjo, it's correct. Then for the motor response, we are assessing the level of motricity. If someone is lying down and you cannot assess the limbs because they cannot flex them, they can extend them, but they can at least localize the pain. They can at least obey commands. So for a tetraplegic patient, it's a little bit challenging because you do not know where is the level of motor injury. Okay, the only way the VAO does not apply if someone who is intubated because there is no way they can talk because they're intubated. In that case, you use what we call the T, Glasgow score plus T. Okay, question? Any question? Good, no question. Let's be quick so that we can finish. So for exposure, you look at what the patient has.
Excuse me, what is T?
T means tube. There is a tube in the mouth. You will see sometimes in patient's file in ICU where we write 8T, 6T, 9T, or 4T. It means we have calculated the eye opening, the motor response, but we remove the verbal because the patient is already intubated. That's why we call it T. Sylvia? So for exposure, you have always to pay attention to the triad of death. You have to prevent hypothermia, you prevent hypovolemia, you prevent always log low, rest the patient and look for any wound in the back, in the chest, in the buttocks, on the legs. So you have to reassess the ABCD if the patient becomes unstable. Always assess airway, stabilize it. Assess breathing and stabilize it. If A becomes unstable, return to A before you go to C. Assess and stabilize it. If B becomes unstable, A leave C and return back to B and A. Never progress if the first letter still has instability. Okay? Good. This is an example of a patient who is really well not managed because these are not personnel of the doctor. You have a trauma patient, there is no airway control, there is no C collar mobilization, there is no log lowering, there is no examination. This is a catastrophic transport of a patient. This is another catastrophic transport of a patient who possibly have trauma. So you should never do this. You can see the problems on these pictures, okay? So now this is another example of injury, explosion in a grenade where you can see all of the problems by the personnel who forgot to put a C collar. I like to give this image because they have put the IV lines, they have started to give blood, but they forgot to immobilize the neck, which is really useless, okay? Good. So secondary survey, you now go with the examination, you know, head-to-toe examination on completion of primary survey, and these are done when ABCs are stable, okay? If there is any challenge, any problem, you come back to primary survey for any deterioration. So you do a head-to-toe examination, you are going to read about this, you already know how to examine the head. Recognize it's one of the example of cranial-based injury. This is what we call ecchymosis, bilateral palpebral ecchymosis with edema, which is in favor of cranial-based injury. This is the Bartle sign. We call it the mastoid ecchymosis, also in favor for cranial-based injury. And this is a typical example of someone who has a crash of the eye, and always follow the same rules, A, B, C, D, E. Don't be impressed. Don't be impressed. You don't start with the most impressive. You start C, D, E, always. Secondary survey, the neck, you assume the neck subcutaneous emphysema. Yes, please.
How can you stop breathing?
Sorry?
How can you stop breathing? How can you stop the breathing?
Bleeding for this patient?
Yes.
Do you think this is catastrophic bleeding?
I know the difference.
So a catastrophic bleeding or a massive bleeding, it's when there is a pulsatile artery. Reka mbishyire mu kinyarwanda, icyo twita catastrophic bleeding cyangwa massive bleeding nicyo bita umutsi uri kududubiza, sibyo? Do you get it now? So, umutsi uri kududubiza nicyo twita catastrophic bleeding. This is not catastrophic bleeding. This is a crash wound. Biragaragara nabi, biteye ubwoba, ariko ibi ngibi biravurwa, ntabwo ari ibi ntibyamwica. Iki gisebe mubona hano ntabwo aricyo cyakwica uyu murwayi. Oya, icyakwica uyu murwayi ni breathing, sibyo? Amaraso yagiye mu zuru, amaraso yagiye mu kanwa, nibyo byakwica umurwayi. Sawa?
Muri cranial part na vasos zishobora guteza
Wapi? Cranial part, catastrophic bleeding, it's very easy. Ufataho ikiganza. Erega, mwikumva mvuga ngo catastrophic bleeding ugira ngo ni umurwayi uri bujyane muri salle dope. Oya. You just shyiraho ikiganza, ari kuva amaraso hagarara, ubundi ukomeza akazi kawe. Sibyo? Yes, the most important to memorize. I'm asking you to memorize. You don't need to have a lot of confusion. A, B, C, D, E. Ubu usinziriye, ubu ukanuye, ubu uri muri Amerika, ubu uri mu Rwanda. That's international management of a trauma patient. Whether it's an aircraft injury, accident, whether it's a bicycle accident, whether it's a fight, whether it's a stab wound. Anytime you see a trauma patient, always ask yourself, is the patient breathing? Is the patient having a clear airway? Then you go to the bleeding if it is not catastrophic. Catastrophic means someone who's having a pulsatile. Catastrophic tubikora ku rugamba mu gisirikare. Ni hahandi umuntu baramurashe, yari asanzwe ari muzima, akaguru karacitse, amaraso, imitsi iri kududubiza. Ntabwo uzajya kureba ku zuru, akaguru kari kududubiza amaraso. Ikintu cya mbere ukora, urabanza ugafunga aho hantu ari kuva amaraso, then you go quickly to the airway. That's my message. That's the message you should retain from the trauma management of a patient. Sibyo? Maze hafi minota 30 talking about trauma. Trauma means A, B, C, D, E. It's an exam you're going to have this time. It's an exam question you're going to have next year. Your final year, when you'll be a resident and when you'll be a doctor. It will be a daily practice exam. Sibyo?
Question.
Yes, please.
Mu kinyarwanda kuri uno murwayi dufite hano ubu ngubu ugiye kuri ABC ugahera kuri airways ukahita ubona n'amaraso yagiye mu gutwi no mu kanwa no mu mazuru, ntabwo ari gutuma umwuka utambuka. Umajije gukontrolinga iriya bleeding, ntabwo ushobora guhita ugenda ukabanza ukarimuvinga amaraso yagiye mu mazuru no mu kanwa kugira ngo airways, kugira ngo umwuka ubone kwinjira, then nyine ukabona kubikurikiza nyine wabahereye kuvana ayo maraso ari mu mazuru no mu kanwa ari gutuma adahumeka neza.
What's your name?
My name is Doris.
Doris, ntubone iri jisho ryameze gutya ngo ugire ngo nicyo cyakwica umurwayi, sibyo? Iri jisho ubona gutya ryashwanyaguritse, ariko sibyo biri bwica umurwayi. Trust me, iri jisho nta ndwana rireba. Uhuye n'umurwayi umeze gutya, sicyo kibazo. Stop being emotional. You are doctors. We are training you to be doctors. Stop being emotional. Igisebe kimeze gutya ni kibi nabi. Yes, I agree. I understand. But it's not what is going to kill the patient. There is no active, highly bleeding from this wound. Only arteries we can have is the temporal artery bahano. always use your anatomy. Temporal artery iba hano niyo yonyine ishobora kubleedinga cyane. Hano uduhaba n'utu arteries dutoya. Don't be impressed by this wound. This is not the problem. Niyo mpamvu yatumye nyishyiraho kugira ngo mwumve the message. The message is not about this wound. The message is here. Do you get my point? Don't be emotional by this catastrophic image you see. There is no catastrophic bleeding from the eye. What we call a catastrophic bleeding, it's an aorta. Aorta which is bleeding, it's a femoral artery which is bleeding, it's a tibia artery which is bleeding. Sivyo?
No, yes, teacher. I'm
Okay.
saying that.
Then I come back. When you are doing the airway, first of all, you talk to the patient. If you talk to the patient can respond. It means airway is open. Sivyo? If the airway is open, you ask the patient, chira, ibintu biri mu kanwa bicire. You put the patient in a lateral position, ukamubwira ngo chira ibintu biri mu kanwa. Kuko yabiciriye ya maraso yagiye mu kanwa, ntago manuka mu muhogo ngo afunge umuhogo we. Do you get my point? If the patient can spit out all the blood in the mouth, they can also sneeze out from the nose. Sivyo? If the patient cannot talk, it means the patient has a problem of consciousness. You have immediately to control the airway by the chin lift and the jaw thrust. Mubyibuke. Nge ntago nabyibagiwe. Sivyo? The chin lift, the jaw thrust kugira ngo ushobore gufungura airway. If the patient cannot open the airway, you put a oral cannula or you intubate the patient. Do you see the patient is intubated? Do you see the tube here? Can you see the tube?
Yes.
Do you see this light one? Muri kubona cursor yanjye hiri, mouse yanjye hiri. There is a tube which is mouth because the patient could not control the bleeding. No, sorry, the airway. Or because they intubated for anesthesia. Okay? Don't be by this blood. No. Just ask the patient to talk. If the patient can talk, it means the airway is open. Patient airway is open, go to the chest now. Look at the breathing movements. If you have any hemothorax, if you have any pneumothorax, if you have any flared chest, if it's none of those, now you go to C as circulation. On circulation, you look at the blood and the BP, vital signs, heart, BP, capillary fill time. For them, you can apply a dressing. You can. Breathing, circulation. After that, now you ask the patient to open eyes. He cannot open eyes. Now you ask the patient to talk. You are conversing. Now you ask the patient to move the limbs. But you will never ask the patient to move the limbs before you control the airway. Ibintu umuntu akora ubikorera icyarimwe. Do you get my message? That's the message. You do it simultaneously, but you know the approach. Airway, breathing, circulation. Ubikora mu minota ibiri. 2 minutes, you are done. Byose wabirangije. Because beyond 2 minutes, the patient is going to die. Okay? So let's continue so that we can finish. So for the chest, you always do the same inspection, percussion, auscultation, but after your primary survey, now we are talking about the secondary survey. For the abdomen, it's a potentially difficult, but beware of hidden hemorrhage, internal bleeding in the abdomen. It's very crucial. Remember always to do rectal examination for the abdomen. Treating wound, you do a surgical exploration. For blunt trauma, you just put a nasogastric tube to decompress the stomach. You don't put a urinary catheter if there is meatal blood, and reassess progressively and frequently. So for the extremities, beware of a compartment syndrome. You look, you feel, but always beware of a compartment syndrome. So don't forget the back. Log roll the patient. 4 persons can do it. Always remember to control the airway. You have a clear timing and instructions and allows the back examination. Okay, this is what we call the log law. Umurwayi umushyira mu rubavu ugashobora kusuzuma n'umugongo wiwe, sibyo? Okay, you see a deformity. This means there is a fracture somewhere here. That's something you have to look at before you go on for other surveys. So then you start for trauma investigations. You do x-rays quickly, a chest, a cervical, a pelvis. And I think that's the end of our course. If you have any question, please ask me before we conclude the today course. Any question?
You clarify.
Sorry?
May you clarify about exposure?
Exposure? What's the question of exposure? I did not hear the. I didn't hear the question. Please come again.
I am asking about those A, B, C. I'm asking about that A, B, C, D, E. On the last one, about
exposure. Exposure is to undress the patient and examine any wound. Exposure means you look for the whole patient. Do we have any wound? Do we have anything we missed? That's why we always undress the patient. Umurwayi wagize trauma baramwambura, umukuramo imyenda yose kugira ngo ushobore kumwexamina ahantu hose, mu mugongo, mu nda, mu maguru, mu kibuno, ahantu hose. That's what we call exposure. Exposure means you expose the patient and examine well the patient so that you miss anything. However, you prevent hypothermia. You have undressed your patient, you have to prevent hypothermia. Sawa? Any other question?
So please, how do you manage exposure and preventing hypothermia?
Hypothermia, it means you expose your patient. After exposing the patient, you be very quick for not exposing for too long your patient undressed.
Thank you, sir.
Any other question? Okay, so who is the team leader?
Yes, sir.
Who is the team leader? Okay, I want you to send me your email, your class email. Please, you can send your email so that I can share with you. Yes, please.
I'm around.
You are around, please. You can share with me your email. I'm going to give you my phone number. I'm sharing it on the chat. Did you see it? If you have any question, you can text me on WhatsApp, but share with me your email so that I can give you this presentation. Remember when I was discussing with you this topic, there are some slides really noted too much, and I said even these exams, I always like to is important in my topic. Okay, I hope it was interactive enough. If you have any question, you can ask me anytime, anywhere.
and we will meet in the exam. Okay?
Yes.
Okay.